come to the 1987 Act, then again it was more of a treatment. So basically the person, the mentally ill person, did not have as much rights. So if I wanted to get treated in a particular way, or let's say I do not want certain types of treatment to be done onto me, I did not have a choice. Yeah? But then the 2017 keeps the person with mental illness, as the focus. So when we look at if you were to ask me, okay, what does this act aim? So basically, like I said, it aims to provide mental health care, quality mental health care for people with mental illness, and it's basically, the main crux of it is to protect the rights of the person, so rights of the person with mental illness. Again, I want you to notice that we are talking about rights of the mental health person, a person with mental health illness. We are not calling them mentally ill, because there are certain terms itself which are derogatory, like calling people by their illness, like for example, saying somebody is mentally retarded, somebody is schizophrenic, because if you look at the terminology, that itself frames the kind of picture you have in somebody's mind. So if you say, okay, this person is a diabetic, we are saying that the person, diabetes comprises of the entire person. But when we say a person with diabetes, we say that this illness is a part of the person. So we give amount of respect to the person. Now, the act is detailed in the sense that each aspect is highlighted, like what is mental illness. Now, if you look at it, there are a lot. If you look at phobia is also a mental illness. If you look at panic disorder is also a mental illness. However, in terms of this act particularly, we are looking at disorders which are more severe and which would have a legal impining. You would not quite find a person having a plea for insanity, or let's say you would not have somebody not being aware of what they are doing, to put it in a very layman's language, when you have anxiety or depression. However, for severe mental illness, there's a need to differentiate that. So substantial order of thinking, mood, perception, orientation, or memory. Basically, this makes a person not aware of whatever is happening around. That impaired judgment, their ability to act, behavior, capacity, and whether they are in touch with reality or not. So here, one of the special provisions also is that they have included substance use disorders, which previously was not there. But this does not include mental retardation. So technically it is intellectual disability. And if you look at disabilities which form a large part of our everyday clinic work, these are regulated by a different act, the right of persons with disabilities. Okay, I don't know this thing. So mental illness and capacity. So if you go by the chapters, like I said, there are 16 chapters with different sections. We would be only doing the ones which are highlighted, because it has more pertinence, especially with regard to what we are doing. Yeah? So basic definitions, like what is advance directive? It's more like a written bill where you document how you want to be treated and what you want to be treated as. Yeah? Then we have authority. So here when we say authority, throughout the Act we mean the Central Mental Health Authority and the State Mental Health Authority. So when we look at the caregiver, when we say caregiver, we say that it's a person who resides with the person who has mental illness and is responsible for providing care to that person. So it might be a relative or a person, let's say, or a paid person who performs this function. Then when we say board here, for the Act we mean the Mental Health Review Board, constituted by the authority. When we say family, again, it may be by adoption or marriage. It does not necessarily only have to be by blood. And then one of the most important aspects, because a lot of legal implications are there for the MHP also. So it's a psychiatrist, clinical psychologist, psychiatric social worker, mental health nurse, or a person with a degree in Ayurveda and a postgraduate degree in related psychiatry, but in their domains. Okay, so here for each profession, so like for example, when we say an Ayurvedic doctor, it's not just an Ayurvedic doctor with a bachelor's degree, it has an additional master's degree, okay, which is specifically related to psychiatry. So like that, the definition of a psychiatrist, the degree he should have, an MD, a clinical psychologist, a license with an MPhil, and a psychiatric social worker who also has a license with an MPhil, a mental health nurse who's a PG in psychiatry. So these are specifically defined. yeah, so there are different types of medication. Okay, I think I am going. Like when we look at the different aspects, no, Unani, homeopathy, Garuda, that is one of the divisions which is. Last one. Okay. I think I'm moving forward for whatever reason. To do with, I think the, what do you call that? Kerala for the Ayurvedic practice, because in Imhans also we have a separate section for that. And I was also quite surprised to know, because when we did our residentship, we did not have that provision. But I think with the new laws that are governing the country, there are a lot of changes in terms of education. So the weird part, I would say, for me is that they actually have like massages and treatments like diets for each type of disorder. Again, this is new to me, like I said, because we never had it. For us, it had to be a clinical professional. So we did not even have people with homeopathy degree or Ayurvedic degree coming in. So they do have an orientation course per se where they come, but they usually are not involved in treatment. So how they are involved in treatment actually, because we don't have any here, in our OPD also, we only have clinical people. So I am really not sure how the treatment goes about. So informed consent for us, this is important, more so because even for research and because we need to uphold the rights. So this consent is for an intervention which the person is agreeing to with his full understanding. So somebody cannot be forced to take treatment in a certain way, or like for example, let's say somebody cannot be forced to take research only based on which the person would be given treatment. Because in a lot of bigger hospitals, I think this is also one of the clauses that I would get into the patient's doctor's list if I enroll in his research. Prisoner with mental illness, again a term familiar to me because I used to visit jail. So it's a person who has a mental illness and is under trial or convicted of an offence and detained. And if you look at the legal population, I think the maximum number of people we have referred to us are the people in prisons. So we'll move on to the next chapter, which again I think is one of the most important concepts that we continuously come across, because when we receive a letter from the judiciary, it's always about the competency to stand trial. Is this person aware that this person has committed that crime? So when there again, previously there were no proper mandates to be followed. Here right now there are so much of paperwork, so much of regulations to be followed, and frankly it's very difficult because we have very limited number of professionals. Like for example, let's say last week I was asked to assess, I think about 10 days back, I was asked to assess 7 prisoners, and I was not in, I was on medical leave, but I got a call saying that there are 7 prisoners who are going to be released from jail, so you have to assess whether they are fine or not. Now obviously in one session, it is not quite advisable to assess, but because of the lack of time, what happens is, if tomorrow they have a hearing or 2 days later they have a hearing, they are brought to us and we do submit a report. For cases in which we feel that there is more time required, we always write to the judge or we always tell the police officer. But this is, I think, one thing that I'm sure all you people, learned people can work on, because it becomes very difficult and it's not fair just to give a judgment. So here when we talk about, most people say that, okay, this person has mental illness, so this person is not able to understand. We need to understand that not all mental illness will, it's not that everyone who has mental illness will lack the capacity to make judgments or will not understand. It is at the current phase. So if, okay, so there was this case wherein a person was referred to me after 6 months. The person was caught in Sada, and then they wanted to, he had shown 1 or 2 abnormal behavior, a little bit of aggression and crying episodes, and he was referred after 6 months to assess, as per the letter, whether he had taken substances or not, whether he was mentally fit or not, and whether he was aware of the amount of substances he was carrying and whether he knew the implications that would have. Now for me to say that this person was fine and he can stand trial and then he would understand, I would not be able to say that based on that time. So it is always the current, so which is what we write, but generally I think what is interpreted by the normal scenario in normal public is that, okay, if we say that they are not competent to stand trial, means that they were not able to understand them. So there's a difference. It is only we can only assess with regard to the current functioning of the person. If the person has had a history of mental illness where a person has been taking treatment and has had active symptoms and we have information to corroborate that, then we do make a special noting in the assessment report. So for me as a psychologist, I do not look at the pharmacological part of it. Of course, it is integrated. We only look at the functioning, the psychological functioning, the cognitive functioning of the person. So whenever the person is assessed to us. I'm sorry? For the person with substance use. I think it was brought from the police. I think then, if I'm not mistaken, it was lodged in Rani police station. I have no idea who signed it. No, the court had directed and they had gotten. We usually keep a copy, so probably if I look at it, I'll let you know. But it was a very random request, which obviously you understand is not sensible. Yeah. That would be a whole lesson altogether. It's actually like a curriculum for us. So we do have certain criteria, okay? So let's say for schizophrenia, for example, one of the main disorders I think which you would see in your court saying the person has had schizophrenia. So here the symptoms have to be there for 6 months. So if I come with psychotic symptoms today and the doctor says you may have schizophrenia, that would not be a diagnosis which will hold good in court because I've just been diagnosed. So we can only write psychotic symptoms. So for most disorders, we have a series of symptoms out of which at least 4 need to be fulfilled, or there are different categories for which at least 2 has to be there in each domain. We will touch on it a bit when we go to the Mental Health Awareness Act. The diagnosis itself is a huge chapter. However, when we discuss in the next half, we'll be talking about severe mental health disorders. There, I think in the court, if you look at it, a majority of population who contest that they are not sane, they would be the ones with those disorders. Is that fine? So again, when we say mental illness, we use it very loosely. So we can only consider somebody to have a mental illness or call them people with mental illness specifically only with regard to what the person's treatment is going to be and how they are going to be treated. So again here, the basic part is, the person who we are saying has rights. So we are saying that basically the person has the right to decide his treatment, the person has the right to have a choice of treatment. Now of course there are a lot of repercussions because there are indications which would not be right for the person. So here, one, you understand the information relevant to the mental health care. So I have schizophrenia, so I understand what it is and I make a choice. Okay? So very simple example, there are certain antipsychotic drugs which are used. Now for those antipsychotic drugs, obviously you will have side effects. Okay? So if I am able to understand that this is my illness, this is the line of treatment and this is what I would prefer. Okay? So then, and the consequences of using that or the consequences of that decision, then we would say that somebody is capable of making decisions. And here as per this act, we say that everybody is capable of making a decision. So no person is incapable. And if we say they are incapable, we have to prove. And for that there is again, each question we ask that has to be noted. So there has to be a formal note for everything. So like I said, there's a lot of paperwork which happens to be a little cumbersome for us when we are in the OPD. And we do not get the whole day to assess a person. The second is retain that information. So if I talk about it now and let's say 5 minutes later I'm not able to understand or I'm not able to repeat what I've said, that would also mean my cognitive capacity is not intact. I have not been able to take that decision further. So this is one. And again, like I said, knowing the consequences, knowing that what weightage my decision will hold, being aware of the consequences and making the treatment decision. Also communicate her decision by any means. So whether it's by, let's say for a person who has a hearing impairment, by sign language. Again, unfortunately, we do not have registered personnel in our department, which technically is supposed to be. So there are a lot of clauses which sometimes, if you look at it, is not quite feasible. We're still working on it and there are a lot of issues. Like last time, I think there was a referral wherein a person who was had to be assessed, and the person was short of hearing, had hearing and speech impairment. Now, for me to assess the intelligence of the person, because there was a complaint of sexual assault, and the court said that they needed to understand whether the person was aware of what the person was reporting. Now, for me, it becomes a challenge to assess because I do not have an interpreter working with me. Okay, so our basic assessment would be dependent on what, again, the National Disability Board has qualified. So here we look at the social age of the person. So then again, I mean, if you practically, logically look at it, a person who has hearing impairment and speech impairment obviously would not be able to do the function as well as you and me, because again, I mean, literally if you look at it in the society, they say, Lotte protha, Sogdaina, Gardaina, so they are not even given a chance. So obviously when we assess the capacity, intellectual capacity of the person would be lesser. So we have certain assessments in which we can calculate the IQ, the intelligence quotient of the person based on the social functioning. So these are the kind of tests we use. So like I'm saying, these are practical difficulties because we do not have enough personnel to be able to carry that out. Now, advance directive. Now, everyone who is not a minor shall have the right to make an advance directive in writing specifying the way the person wishes to be cared for and treated. Now, I cannot say if I have a mental illness in which, let's say one of the symptoms is aggression or violence, I cannot say, okay, when I'm ill, I would not want to be treated, or I would not want this drug to be used. You can, but you will have options. So again, for a person to say how he is treated and how he would not be treated, the directive has to be made when the person is not, when the person is well. If I have, let's say, bipolar affective disorder, if, let's say, commonly known as mania, where a person is making false claims like I am God or I am somebody who is great and I need to be listened to. Now, if I write a directive at that time, obviously it will not make sense. So this has to be when the person is all right, not in an illness phase, and it will hold good only till the person is well. So this is time specific. So the way a person wishes not to be cared, and who do I appoint as a NR, nominated representative. We'll come to that next. Now I can have one nominated representative, I can have a few. And so let's say the first NR is not available, then we go to the second NR. So usually people do have one or two. It can be family, it can be somebody else also. So now for an AD to be registered, we can only register it for an adult and not for minors. So a legal guardian can apply. So people with mental illness, PWMI, will document it in a form and register to the Mental Health Review Board for the resident area. Now it has to be signed by NRs and 2 witnesses during registration. The Mental Health Review Board will maintain online register. So as per the law, like how we have it in Remand, we have an online directory. So for every person who comes in and is admitted and who has an AD, we would be notified. But here it has to be, so here let's say I bring a person who has an advance directive. So I as a nominated representative, I have to present it to the treatment team. So if I do not present it, it would not be considered the fault of the treatment team to not follow it. Okay, and the Mental Health Review Board also has to send an advance directive. And if you really look at it, most of the time patients who are admitted, the families do not disclose this information. And from what I see, I don't think we have many people who have registered for this. Because we do not, till now, in the last 10 years at least, I have not seen anybody who's come with an advance directive. It has to be signed by 2 NRs and 2 witnesses. They'll maintain a register, and then within 14 days of registration, they have to be, and they have to process it within 14 days of registration and present it to the working team, the treatment team, when required. Now again, there was a case wherein, not here, there was a case wherein a particular antipsychotic was, in the AD the person had written that I should be given X injection. Now obviously that X injection does come with side effects. So when this person developed dystonia at the side effect, then they cannot blame the team, they cannot blame the treating team that they gave me something which had side effect. Because here, when we say a person has right, they obviously also have the right to go and complain against the institution. They have the right to complain that they were not treated as per the rules. Now, if I've written that, then I will not be, then I am responsible for what I've written. The treating team is not responsible. So this is one of the major limitations, that sometimes when I make treatment choices, I may not be the right one for it. But as per the law, people with mental illness have their rights, and sometimes it is construed a little not in their favor. Okay, so now when I say, okay, so let's say I have a written directive now, and I have a past history of mental illness wherein the directive was not used because I had not made it. Now, irrespective of that, the AD should be followed. It, like I said, it is time specific. So it is followed when I'm not well. So whatever is written as, okay, this is how I want to be treated. This is like, let's say, I do not want ECT. Now, ECT again is a particular form of treatment of choice only for certain disorders, okay? But then let's say I have improved well in my previous episode with ECT. So technically, logically, you would think that, okay, this person responds well to ECT, so let me give it. But if the person has written that no ECT can be used, that even though it is beneficial for his illness, we cannot use it. It's effective only till the person regains his capacity to make decisions. And again, an advance directive may be revoked, amended, or cancelled by the person who made it. Now, the mental health professional can also contest that this is not, the right treatment, or this is not something that that can happen, or if, let's say, the nominated representative is not acting in favor or in better will of the person. But we'll have to we'll have to send a review to the mental health review board, and that itself, as we know, takes time. Okay, so yesterday we had this case, a very young girl, I think a 21-year-old girl was suicidal, and she did not have any family members, so she had to be admitted. Imagine at 6 o'clock, obviously I will not be able to reach any social welfare officer, I will not be able to reach the mental health review board. So just yesterday we were talking about, here we are sitting and talking about mental health law, we are preaching it, but how feasible is it for us to practice? So finally, I had to make the call to the family and request them to come. Now, they have risks, so they didn't want to come. So then we had to say the legal, repercussion would follow. So, like I said, it looks nice on pen and paper. It looks nice when we discuss it like this. But there is still a lot of work that needs to be done when we are implying it. Okay. So, the Central Health Authority can make regulations and modifications. So, they have a state mental health board, they have a central mental health board. So, previously, in the previous laws, it was all the power was with the team, with the government or with the treating team. In the first one with the treating team. So, and then the second one, in the second law with the government. Okay. So here now they have different bodies which only look at the mental health rights of the person. Like I said. I'm sorry, I didn't get you. So, it's a mental health professional. So here, there are 4 of us. So, there's a psychiatrist, okay, and there is a medical practitioner also, because in most hospitals they will have an MO, so a medical practitioner. Sometimes it will be both, like for the girl yesterday, medicine would be a part of this, because obviously she would have to be, her stomach would have to be washed, and she'll be kept under 48 hours of observation. So here, in our context, it will be the medical practitioner, the psychiatrist, the clinical psychologist, the psychiatric social worker, and a mental health nurse. And quite surprising, yesterday when I was looking at one of the reports submitted in Parliament for the Northeast region, the mental health, report for the Northeast region. So this is, I think, submitted from Assam. Okay. The funny part was this is submitted at a national level, and the number of psychiatrists in Sikkim was the lowest, except for, when I can count on my fingers, they are about 17 or 20. And there were 0 mental health nurses. I have taught 4, and there were 4 psychologists, clinical psychologists, which was the only part that was true. Maybe because they were able to figure out the register. So imagine for a person, like normally, per lakh population, they should have at least 1 psychiatrist. Here in India, we have 0.04 psychiatrists and 0.07 clinical psychologists. So number of registered professionals itself is very low. So when we look at all of this, the legal aspect of it, putting that into action becomes a lot more difficult. We can, but if you look at it, the people who actually were involved, in this, in making this bill, the person, I'm sure, I don't know, I will talk to somebody if they can have him here. He's a PhD in law and a forensic psychiatrist. For who can I say? I'm sorry? Uh-huh. I don't think I have access to that politics. Yeah, but then do you think? I wish I would have this. No, it was discussed in the parliament, yes. So that is the absurdity of it.
Sometimes the way the questions are asked in the doubt also, questions will not fit the criteria. Offices, what they usually do is zero, because it does not fit the exact criteria. Without speaking, we are sending so many replies. Questions are framed in such a way that you do not know what is being asked. So we usually don't give that data, it does not fit the criteria. But you can see that reason.
Okay, I might agree to that in maybe in a different context I would agree to that, but the registration itself for a mental health professional, for a psychiatric social worker, for a clinical psychologist, a mental health nurse and a psychiatrist, they are associations which already have the list of the number of people, because you have to register to practice. So that is why the data seems quite absurd, and so what you're saying is absolutely right. I think I'll have to try to figure out a way to do that. Maybe I can come to you for help to do that. Because I don't think it can just be a comment like I can put, right? I'm sure enough to do that. And if I have to draft anything, I'm sure I'll come to you. You see, I mean, talking about what is there on paper is one thing, but as a clinician, what you face is again something different. So a person who's not a minor cannot have a nominated representative. And to be honest, if you ask me, this is a sad case, because there are children who are young as 15, 16 coming in for therapy, and I mean, in the government hospital, thankfully it's free, but their parents don't allow them to come. So after 2 sessions or something, they say that, when they miss their appointment and we try to reach them, they say that, ma'am, my father found out or my mother found out, and they do not want you to come. Now basically, I think a lot of it has to do with the stigma. Sikkim being a small place, everybody knows everybody. And I think that's also where a lot of help seeking is hindered. So here when we say that minor does not have the right to appoint a nominated representative, so technically it would be the parent, the legal guardian, right? So that itself becomes a problem. So for yesterday's case, her legal guardian could not come because he was at work. He was aware of all of this because he was a police officer, but at the same time he was not able to help the situation. And then they tried contacting the family didn't want to come, so it's still a mess that I have to sort out after I'm done with this. So the nomination, like the previous AD, has to be written on plain paper, and the person, so if I am put in as a nominated representative for somebody, I also have to be competent myself to fulfill the duties. So let's say I develop a mental illness, then I would not be the right person to fulfill the duties for the person who's appointed as NR. So for that again, the board can step in and appoint another person, or if there are a list of, let's say, 2 or 3 NRs that I've appointed, then the second person on the list can be an NR for the aggrieved person. So here we have this concept of, supported decision making. Okay, I think I'll skip. Okay, so here we have this concept of decision making. So proxy decision is, okay, so if I have mental illness and you think I'm not fit enough to make decision, you'd make a decision for me. So here, like this professor that I was telling you about, he gives a beautiful example of marriage. Okay, so arranged marriage, in this case where I do not have a say, where the person does not have a say, is what you call a proxy decision. The decision is made without the person's will in context, without the person's wishes. Okay, so that is not something that is encouraged, but this was what was encouraged in the previous laws. Like I had the right to make a decision. Like my family member falls in, I decide how the person goes about getting treated. There is something which is shared decision. So this is love cum arranged marriage, wherein I choose somebody and then we sit with the family and we discuss how it's going to be, or who will I get married to, whatever caste and all of that. So that would be shared decision making. And the other one is where the person with the mental illness, okay, so here in this case, I alone make the decision, my family makes a decision, or we both make a decision. So here in context of the persons with mental illness, it's a shared decision. Technically, if you look at it from a feminist perspective, then again, I think it's also a choice, no? I know, and the statistic I think has increased over the last, the rates of divorce have increased tremendously. Socially, if you look at it, like, I mean, normally also in any illness or in any relationship, we have a lot of reasons, okay? Psychologically, I think it is the independence, you have to make decisions. Like for example, if you look at one of the basic reasons why divorces are increasing is because now people understand that it's okay to walk out of an unhealthy marriage. People have their understanding of what I as a wife or a husband cannot do. So the social change makes a large part of it. And I think the economic independence of the person. Okay, so if you look at it, if it's mostly, I don't know who it is who's filing a divorce, I mean, I'm sure you'd be a better judge of that, but if it's the woman, previously because of a lack of income or lack of resources, the person would not, and again the societal taboo, like I said, a lot of people don't come for mental health work because of the stigma. A lot of people would not get divorced also because of the stigma. So, one reason, the economic independence of the person to decide that I can have a better life outside this marriage, the social implications of it that now divorce is not so much of a taboo, although I think in Sikkim it still is, because there are a lot of people whom I know who've come for therapy and are not able to. And on the other side of table, I think I know a couple of people who are coming to me. I think their case has been running for 4 years or 5 years. So the amount of, agony that they face while the case is going on, I think is much more than what they were facing in the marriage. So at the end, they begin to, in therapy, they begin to question the decision. Would it have been easier if I had stayed on? Research-wise, I can only give you the psychological and social reason for it. I think it's also a matter of fit, at what age you marry, like people who marry young. Also, as with time we evolve, right? Our likes, dislikes, the way we look at things changes. So I think the misfit can also be one reason. What do you see, sir, as one of the reasons that people quote? How about you? Has that? No, has that made you question your marriage? Because see, when people come to us and they say, okay, this is what my husband said and this is what my wife said, and then you think, oh, did my husband also say this? That is also a problem. But what if, let's say, there's no guidance, but they are absolutely not the best selves in the marriage? But in the cooling period, see, I mean, technically, I think as per law, that 6 more months they have to come for counseling. People don't come here, they're psychological minded.
That's what I can actually. In 99% of the cases, no one comes to me. And in fact, counselors, I don't know what is, I don't understand what the counseling report comes. So far, I have not got any report which says that the counseling has worked. So, in fact, that process is not agonizing. Already I've read of the rights.
And so if you ask me, in the last, I've been here in Sikkim for the last 10, 11 years, I have not had people coming for counseling. When they are actually in a relationship, not marriage, they've come for counseling. They've fought, they've worked out the issues and gone. But people who filed for divorce, they have not even one person has come. But people who filed for divorce and have gone through the women's commission route, they are, there's a dictum, right, that they all have to be rooted. So only the spouse who's aggrieved comes, but we've never even been able to reach across to the other partner.
Whom could you contact at night, the medical review board or submental something board who said you not see till the night? You will find particular officers and
I think,
That's so many loopholes in their program.
yeah, sir. So coming to the qualification part of it,
Before Sikkim, where you said 15 years, but on 11 years in Sikkim.
10 years here, 5 years in Bangalore, sir.
Thanks. Doing what again?
Yes, sir. Clinical practice and rehabilitation. So it was more of clinical cases. Here it's a mix of everything.
Study.
Uh,
Because you haven't given me introduction.
I think you did really, you're not listening.
Your qualifications and all.
Yes, sir. The person who introduced me actually did. So for
This is short-term memory loss.
maybe you can come and I can evaluate you and give you a report. So technically for a person to qualify as a clinical psychologist, the person would need a licensing. So that is from the Rehabilitation Council of India, and that is only after masters we have an MPhil course, a 2 years residency program in a mental health institution. Only post that you can have a license, and that hospital or the organization, the college which you pass out from, that also has to be registered with the RCI. It has to be approved by the UGC, of course, first, and then it has to be recognized by the RCI. And like I said, there are only 4 of us in a lab population, I think 7 lakh plus. That also makes the world all a little more difficult because, like, say, I am not interested in marital therapy, okay, but if a case comes, I have to do it. Like, I cannot say no. Like for us in cities, what we would do is, if somebody comes with, for marital therapy, I would always tell them that this is the person who specializes in that and this is the person who you can go to. Or if my client has, let's say, anger or even, one of the common things, admiration or attraction for us, then it is our rule to refer that person to somebody else. Here in our case, if it is a family or relative, I cannot see. Half of Sikkim is. And the other thing is that if the person has issues, I cannot refer because there is nobody else. So it becomes a lot difficult. And I think one of the main things that I see, people don't want to come to the hospital. So having requests that can you come at home, or can I come to your house, or can you practice in a clinic. So I think that stigma part is, I think, a whole lot.
Someone is attracted to the psychologist.
Yeah. So with mental health professionals, with psychiatry, even when
What do you do in such cases?
you have to mark your boundaries, you'll have to ensure that the session would only focus on discussing the mental illness and you do not entertain it otherwise. And this happens all over, like the illness that we're discussing about mania, no, sir? So here, they have a lot of feelings. So even, getting sexually attracted to the person who's treating them, becoming very exorbitant in their ways, like making sure that you are well dressed before that person comes for rounds. Especially in a bigger hospital, you get to see more of it. Here, at least, we can control it to some point. But in therapy setting, it becomes very difficult because it's a shared space, right? Yes, sir. And that is taken care of when it's a bigger hospital because you have appropriate security guards. I think in our setup, it's still a difficulty because there are very few security guards, again, for hospital reasons. And sometimes the patient is so violent that they are not able to control it. The person. So if you come to a psychiatry ward, you will see how many doors and windows have been broken. No matter how you replace it, it always gets back to the same. So anything here? We pretty much. So basically, a nominated representative goes on to help the person make the decision, follow the directive, and again, the person can also give consent for research. So for minors, it is usually parent or legal guardian that is appointed, or the person who is the main carer. So, I think day before yesterday, our child had to come for assessment because we had to send him to a special school. And here, in terms of, they were not by court notified as nominated representative or the legal guardian, but the grandparents were taking care of it, even though the father and the mother were still alive. But this child had been residing with them for 7 years for assessment purpose. They were the ones with whom I could get information. And the family was not in touch with, the child was not in touch with the father and mother. So here, there are cases wherein we have to work with what is there. So the rights to access mental health care, that it should be at par with physical health care, and then I cannot be denied mental health care. The right to community living, Here I have a question that I would like to ask, because this question has not been answered. So we say right to community living, so which means a person who is unwell, after the person is treated or even during the treatment, the person has the right to live as a respected member in the society. Okay, so I'll not name the clan. So there's a particular association of a particular class. They call it like whatever Samaj. Okay, so apparently this person, my client, jumped from a two-story building, attempted suicide, and when we explored, we found out that the reason was the ostracization. The entire village would not speak to them. The entire village would not call out for any function, not even, they were not even allowed to go when somebody in the village passed away. So basically the husband and wife were on their own, and these people were married, but they were previously married to somebody else. They were legally divorced, and then, they were living together. So in that case, and I didn't know we had such cases here. In that case, the wife wants to leave the village and go, and the husband says, why should we leave? We've not done anything wrong. And they've been living under duress like this for about 3 years. So finally, the wife could not take it anymore. She was having depression and she was taking treatment for it, and the attempt was made. She was saved, but the sad part is, it took only when the husband came back on time, he was able to bring her to the hospital. The people in and around who were not talking to her knew, but they were not able to help her, even the family members. So in this case, we treated the person. But then, once the person goes back, it's going to be the same. So I, from whatever knowledge I had, I suggested that they write an FIR or a GD in a police station, and then go and seek help from legal authorities, SLSA, because that was the best I could do. So is there anything else that could have been done? So these are the cases which are coming in. Sometimes, as professional, no matter how much you try to help, once they go back, it's going to be the same thing. The person has not come back to follow up, so I don't know what has happened. And we do not have a system like that in the West, wherein, you have a social worker who goes on and checks. So usually there's a social worker and a mental health nurse who goes on and check with people, like why they've not come for follow-up and all. But with our population, it is not possible. So we do not have that, a law. We do not have that practice in India. So I was just wondering, apart from this, sorry? Pakyong Gocho Masa, somewhere Pakyong district. But this was before Pakyong, that time was not declared as a district. Pakyong somewhere Varakotya, and I did cross-verify with a psychiatrist who's from there. He said it's there, and honestly, the answer to me was like, hospital mata illness ko lagi to treat kon, social issues mata ani kuta something. But for me, if I'm looking at the welfare of my client, I obviously have to look at the picture, right? So here I felt at loss as a clinician who's been practicing, who knows a lot. There was nothing I could do. And then again, we do not have a social worker in the department, FRI, so then we cannot even, ask them. So NGOs, sometimes we can reach out to them, but we do not have active people here. So in Manipal, we have one person who gets people from Darjeeling and the Doors area. So at least if I was there, I could have, it was in those areas, I could have reached out to him. Here, I am at a lack of people to go to when such kind of cases come. Then I think again, here, you isko kamo, this person has to do, you amro kamo, this is what we have to do. I think that restricted concept is also becoming a barrier to treatment. And I know these kind of cases are coming in a lot. Okay, so protection from cruel, inhuman and degrading treatment. This has got to do more with training. So previously people were chained, so when I was studying, we had a separate ward wherein people with mental illness, prisoners with mental health issues were kept, and people who were aggressive, violent and who were at risk for others were kept separately. So there were people who were chained, their hands were tied. So these kind of treatments you would not see in the hospital here, and this is exactly what has been banned. Equality and non-discrimination, which is exactly what I spoke about, it is not happening. Right to information. So I, here according to this act, have a right to access my medical records, and if the mental health professional or the hospital refuses to give it, I can file a complaint with the mental health review board. However, there is also this clause wherein if I do not put something on paper, then I have to record it, and I can only give it after the mental health review board gives me a clearance. I do not have to put everything down on paper, especially only those, here again, only the information which would be contradictory or which would not help the person aggrieved. Right to confidentiality, discussing details. Now here, like I said, when Sir said, okay, which place I could I said, but obviously I cannot give you the person or the community's name or what transpired. So especially I think families come to us, or the husband comes to us and says, okay, I would like to know what my wife is saying and what has happened. Or teachers come, send the student and they want us to write everything that is there. A lot of students complain that they cannot go to the school counselors precisely for this reason. So then again we are at a loss, because we do not have appropriate people to, again, refer the person to. So the right to confidentiality is something we must uphold, but this itself also is a question, is also a battle that I think we need to fight on a better footfront. Release of restriction on release of information in respect of mental illness. We had this case recently where somebody was pictured taking her clothes off somewhere, I think near the district court, where the person was filmed, and then this entire complaint happened and the person was caught. So again, we cannot disclose pictures even for research purposes. If we are putting up pictures of patients in like certain states or with certain illnesses, we always need an informed consent from the patient. For research, it is very clear. For people with mental health illness, this is only coming about now. To access medical records, like I said, to personal contacts and communication. Here again, you are allowed to reach out, call, email, or send mails, which obviously doesn't happen. But in the hospital, it becomes a problem. A child who's come, or a person who's come with excessive use of mobile phone, okay, now we cannot not give the person the phone, but as per the right, we have to give the person the basic rights to communication. Especially when there is a problem with gambling. Like I had somebody who had gambling disorder, and this person, even though it is his right to have a phone, we did not have any option, but of course we requested him. So with permission, he had given me his phone, and he was using his mother's phone only for basic contact purpose. So till the end of therapy, which was about 5 months, I had his phone with me, and after we were confident enough, and he was confident enough that he would be able to manage, we could give his phone back. So even though it is a right, sometimes we may have to work against it. A right to legal aid, right to make complaints about deficiencies in provision of services. Now this is important because sometimes what happens in a hospital obviously is also not fair. And previously there was nobody that they could go to, only the medical superintendent. And what I see as a common misconception is people with mental illness will make up stories and you should not believe them. So they'll manipulate, they will make up stories. So this, at least, like if they are not satisfied with the way the treatment has been done, or say I have been rude or insensitive to the person can always complain to the mental health review board and it will be taken up. So here we spoke about services. Now we also need to see these are access to inpatient, outpatient or rehabilitation and other homes like free treatment for BPL and destitute. Okay, there's also this clause here, especially for people in Northeast, that if there is no mental health care services provided at that particular hospital and within the next district, then they are liable for compensation. The state government has to compensate them. But I do not know of any case where a person has filed a compensation, but that the right says that everybody has an access to care, and then they can the travel, the money spent on the treatment and the accommodation, whatever costs were incurred, they can claim that from the government. So here, halfway homes, sheltered accommodation, supported accommodation, home-based rehabilitation, hospital and community-based child and old age mental health services. This again, we've been having a problem because a lot of people are, we find it a task to ask, the services. So social welfare is involved, but it becomes quite cumbersome for us to relocate. There was a patient who was with us for 5 months, and from the first month itself, when the person was fit to go, she was a destitute, we've been aligning with social welfare to put the person in a respected community. This was a 45-year-old woman, but she remained in the hospital for 5 months because there was no provision made. The letters went unanswered. So this became this was I think a year ago. So and the issue that I'm talking about, like the patient we saw yesterday, that will also become an issue because the family doesn't want to take responsibility, the legal guardian doesn't want to take responsibility. So I think again here the social welfare needs to be, in the loop. So these issues, even though it may look like it doesn't happen, these are part of our everyday hassles. Okay, so when we said cruel, inhuman, and degrading treatment, there were, I'm sorry, there's a repeat of the word. So there were cases in which in hospitals people were not given basic provisions as, sanitary wear or undergarments. So now the rule specifies, and then there used to be a hospital dress, like everybody, had to wear that dress. But now you can have the clothing of your choice. You can, whatever clothes you get from home, you can have that. It may seem like a small issue when we look at it from a broader angle, but if you look at it closely, it is the identity of the person, So you're not some number in the hospital. You are an individual who has rights. Education and religious practices within the mental health establishment, which is there, I think, in your prison, but in the hospital, we do not have provisions. Because again, our hospital-based treatments are acute, right? So once the person gets well, we generally ask them, or we generally refer them. Like in Bangalore, we always had a couple of options, like halfway homes, or the psychosocial rehabilitation centers, where not substance use, but you would admit people with other disorders, so we could send them there, and all of these facilities were there. But here, if we send them to, let's say, halfway homes, we obviously there also we do not have mental health professionals working with that home particularly. So they still have to keep coming back, and the facilities as such are there, but then how much it is utilized in the form of treatment, that is also a question. Okay, and this, the point number E, not to be forced to undertake any work in mental health establishment and to receive appropriate remuneration for work. This, as far as I'm concerned, is the biggest problem in rehab. Because when you go, they say you are expected to work in a certain, way, like somebody cooks food. I mean, in all the rehabs, if you see, but that work is not paid for. It's considered to be being treated, as per the rehab thing. So a lot of rehabs also had a problem when they had to be registered, because all of these clauses have to be followed. And we do have few rehabs registered, and I think when the Mental Health Review Board, they periodically go and check, right? And they, these boards, these rehabilitation houses, or these places which house people with mental illness, their registration is temporary in the beginning. So only based on these conditions, they are fulfilled. I don't know how much of it has happened, because when I last checked, people were still doing the regular duties. So the rehab did not have staff. The rehab was run by the people who were getting treated. Now again, this is what we talked about. Okay, one important thing, if you remember, I don't know if how many of you are aware, but usually when people were admitted to hospitals previously, there was tonsilling, right? They would cut off their hair. The basic reason was hygiene. Okay, but then this is not the norm now. Previously, it was for everybody, irrespective. Like I said, the water work for everybody had tonsilling, it was compulsory. But now with all of these laws, small changes have been made, which preserve the dignity of the person with mental illness. Okay. So this is what we discussed, that the illness has to be, the treatment has to be at par with provisions for healthcare, other physical healthcare, and it has to be of a good quality. And so again, who assesses the quality? There is a guideline for assessing the quality. But if you ask me, the whole of India, I mean, not even a few states are following it. Because I think for us, we saw that being followed in our institution where we're studying, because it's a bigger institution, they have all the rules in place. But for smaller hospitals or for smaller states, this all is still what I see a problem. Now again, obligation of the state to provide emergency services for mental illness, such as ambulance, adequate and proper living conditions, similar to physical illness. So again, all of these have to be free of cost. And when the costs were actually compared, with the current population in India, if you look at the state allotted budget, it is not feasible or it is not possible to provide people with all the facilities listed. So there again, when all of the people who have formed the so when in academic discussions and all, and in research, they always say that okay, now we need to revise this because it is not feasible at all. And another important thing about this law, which was a loophole which we found, was usually it's the family members who are caregivers, right? By default, like sometimes you don't want to, but you are forced to. So here, the rights of the fact that the person's rights do not include being taken care of by the family. So in the case that I mentioned yesterday, I mean, we'll obviously tell them that, oh, it will be a legal case and this and that, but then technically they are not, their contribution is not acknowledged. At the same time, they cannot be forced to care for the family. There's no rule which protects. So health insurance, if you are aware, for mental illness, that was not provided, except every time in the clause there would be except mental illness. But this is something which has recently come about, that now the mental health insurance for people with mental illness, the health insurance has to provide them for treatment. There are a couple, I think there's National Health Insurance, which has provided. There are 3 insurance companies who have agreed. The rest, I don't know. We had a case, my friend, we had a case in Delhi because of this. So that's how I came to know that, okay, now when a person asks me what insurance to use, I can actually tell them which one to opt for. Right to information. So if I'm admitted when I am not well, I may not be in a state to think of why I was admitted, how was the procedure. So all of that information I can get from my treating team. It is my right to get it. And the NR, the nominated representative, also has. So here it's not saying, people saying that, no doctor, I know, process, and things like that. I need to be know. Just like how we sign the forms before surgery, wherein you are kept abreast of whatever the complications are, which obviously scares you more. Not knowing sometimes is good, but then we have the right to access that. So now the same is available for people with mental illness. Again, if you ask me, a lot of people would prefer not to know, because they'd be like, they would zone out in between. So again, what we do is the information we provide is dependent on the person's capacity to understand and the person's capacity to withhold that information. For a person who's very anxious, giving information about how they might be for the development of the illness and how you may have to take medication for a longer time would obviously cause more anxiety than relief. Again, the treatment procedure in the patient's language. So usually in a hospital, when we have the file, there's always a form attached to the file in which the person is explained that this is how the treatment goes and this is what it will be in their language, and they write it in their preferred language that I, XYZ, as a guardian or as a patient, I'm aware of all of this has been explained. Again, for safeguarding purposes, so that at least is a norm that is being followed. We spoke about this, that accessing basic medical records and specific information can be withheld when necessary. And we also need to inform them of their right to apply to the concerned board if they are not content or if they have any issue with the services provided. Now, duties of appropriate government. Here again, there are a lot of stakeholders, social welfare being a huge part of it. Wherein promotion of mental health and preventive programs have to be done, creating awareness about mental health and illness, reducing stigma associated with mental illness. I think a lot of the first 2 points are being done by legal services more than anybody else from what I see or what I have seen in the last 10 years. Because there are very few departments which have actually organized, apart from the police and the legal services, there have been, I can count the number of programs that have gone through. So social welfare, legal services and police, these are the only 3 departments which we have been having awareness programs. Again, measures to train, like sir was saying, the counselors, that is also a provision that is given. And coordination again among legal services, the police, social welfare, the childcare institutions. Now the State Mental Health Authority, they have a list of people who are supposed to be in the board, who have to be enlisted. So these the chairperson has to be the principal secretary or secretary Department of Health, mission director National Mental Health Mission, state program officer, Department of Social Welfare, Home Department, Finance, Law, member secretary of SLSA, HOD Psychiatry, an eminent psychiatrist, somebody who's a senior practice for a number of years. So here again they have a criteria as to how many years. So you ought to have practiced at least 15 years to be a part of the mental health board. And also representative of persons who've had or have a mental illness, and of caregiver of persons with mental illness. Sure, sir. I'll come to the community hamro like your state mental health board makoko chaile. But the thing is, people don't voluntarily come about. There are very few people who are okay. Sure, sir. The representatives. Sure, sir. And then representatives of NGOs. So let's go on to this. So I'll come to that. I have a list of people who are currently in the board. So person who organizes, I said that previously that the mental health establishment has to be registered. So when we had the last meeting, I think this entire issue of institutions not wanting to register, because if they do register, they have to follow an entire list of duties that they previously were not. Maximum number of people who did not want to register were rehabilitation centers here, because we do know that they do not follow the appropriate norms that are to be there for people to recover. So this was a huge issue, and from what I know, I think a lot of them are provided temporary registration, and within a year, if the services are fine, then only they'll be given permanent registration. Ajay. We tried, sir, but then again, it has to be enrolled through the social welfare. I think, should I say this? They were not responsive. Apparently, the
example is the board itself. See how many members are there. So, government office. So, the comparison is together plus the and you use boards, so the boards.
Exactly, sir. To the district collector.
That's why when the registration problem is, we have seen that in juvenile justice law, the homes, they don't want to register because the government actually are running for time justice. It never comes in time. Here the grievance is, we are running an institution, you don't fund us and force us to get registered also. Law why it forces it? Because they are unable to open the government institution of this quality. So they want the private institution to follow the norms established to the government itself.
It's not following.
So, in fact, when we are going through this, whenever the law comes, the problem gets more. Now, in this one, as you said, there are courtiers also which are mental. Now, what the government will see, the board will see, all the courtiers in a similar manner, they will not distinguish these two different. It's a huge problem, actually.
Exactly, sir. Having a,
I, as an individual, if I have some kind of illness, I'll come to you, get treated, and go back home. If you see this law, more than treatment, there is so much complication.
Exactly, sir. So, Amro Lagiji is probably much the more important aspect for us, for non-psychiatrists, because they would be the first line of treatment. For them, it is the admission part. But then, this Lagiji, there are clear laws like, who can get admitted with consent, without consent, emergency treatment. So, they have guidelines for that. But when it comes to, like you said, interdisciplinary functioning, different departments, it's become a problem. And the social welfare and I don't know whoever it is, but a person director, okay, secretary, you know. Apparently, Dr. Vibhushan, if you are aware, he also goes to jail, right? So certainly let me back a letter, and then the answer was that it is your department, it is your patient, you have to handle it. So this is how, and then sir, if you look at the stakeholder, social welfare has the largest stake when it comes to people with disabilities. that also becomes a problem. The training part and all, yes, is fine. It's like nice to see on paper and then to say, isko garnu parcha, but yes, the implementation part is a huge problem.
We have an experience as principal magistrates. We had a connection to social worker department. Was partner before.
So then it does become difficult because no matter how good you how much ever good you want for the patient, you are not able to achieve that. And again, comparing it to our mental health institute matters because it is of course a national institute of importance, so we have everything in place. So things actually happen as per the rule. So when you come from there, you come here and you see how the things not happening, adjusting to that itself is a mental trauma. So this is currently from 23 August 23 onwards, these are the people who are in the review board. Let's go back to.
So where the law means?
Bahasa यो फ्रिडम रिहेबिलिटेसन सेन्टरको आगे कर्मा मिस्टर कर्मा हुनुहुन्छ उहाँ चाहिँ हुनुहुन्छ हि इज अ सोशल वर्कको एन्ड हि इज बिङ एक्टिभली इन्भल्भ इन अ लट अफ रेस्क्यु हजुर हजुर या उहाँले चाहिँ गर्नुहुन्छ हो सो हि इज द वान हुज बिन एक्टिभली इन्भल्भ इनफ्याक्ट फर मोस्ट अफ आवर प्रोग्राम्स इज बिङ देयर and the funny story again, last time we had this thing for us and our counselors. So we were supposed to go there and the state mental health authority was supposed to brief us on everything and the law secretary was missing. Somebody was supposed to come in place of him and the person who came in place of him spoke about everything else but the mental health act. So this is how it is. So yeah, on paper it looks good, but I think we still have a long way to go. But the person, sir, see, he didn't come for whatever official reasons, fine, But the person who came in place of him, he spoke about everything else but what was there. So for us, because we are a part of it, but for counselors who just joined.
In cases someone else comes from the government, that is the blend and the evidence is paradise. District collector also comes to because even law allows it. Some ABC or something or STNM.
So who came in place of the
I can't tell you, but he spoke about everything in the world, and I sitting there made my own assumptions and if how he needs therapy, what problems he has, because the way he was describing his own incident, and you could see the amount of anxiety that was being masked.
As it is, we need experts in this. Even I admit that this act, even I do not know comprehensively what it entails and what it is. So we need to be thorough in this law to understand that be a member of this group. I can understand the law, but what is it, how it is, what's a matter as a judge and
and out of curiosity again? So bipolar.
I'm sorry, but curious is Teresa.
Bipolar.
And thankfully, no.
Personally, I feel I'm bipolar.
Why?
If I get a certain assignment, the character may proceed.
Isn't that a good thing?
So that's what I wanted to know. Dr. Wilson said, "Hudaina sir."
Bipolar to हुँदै हुँदैन नि सर.
No, once I get sir. I want to validate.
I want to question which psychiatrist told you that tripolar it does not exist in the world, in the head probably.
She's from Mumbai. Bipolar. I spoke about child. He said that okay, 18 years, he has not reached the age of early. There is a concept of accelerated maturity, something which I did long time. And one of the former chief justices was supposed to write a forward for that book. He heard about it. But it is an article somewhere. There's something like accelerated maturity. For example, someone was only 16 years old man, but habitually associated with all those bad elements.
Has the capacity to understand more.
The situation now, as compared to someone who can get into whether habits or temper, whether habits or maturity and all this, yet this was something to try for these research. Today you may laugh about it. After
I have to study again for 15 years. What I would have anything.
That really smart guy, what he was saying, you were a servant, just find it out.
Okay, I will, and I will get back to you on this, but I can bet my life China trip.
Dr. Houston has been proven wrong by the, what's the name, I have a mobile number.
Who is there in Mangan? I think, I'm just student, Kunjang, I think, is there in Mangan.
Till the wife was the prestigious mistake.
No, definitely, I mean, there's no concept as such. The recent updations, and if we were talking about that ILECO book and, the diagnosis, fine. But we have recently ICT 10 JSM4 Juncha, we have a 5 and 11 version of it. It is not there. Maybe research-wise, it is building up, but diagnosis per se, like you can't. So if you do not currently fit into any mental illness for diagnosis. So functions of MHRB, Mental Health Review Board, which we were talking about, register, review, alter, modify, cancel. I think this is what is happening. Appointing nominal representative, that is happening. Deciding on applications in terms of people who file cases, people who have complaints from medical officers regarding, let's say, disclosing information. All that is happening. But again, like we discussed, appropriate channels through which to route the rights. That is still, for me, sitting on the side of the clinic, it is questionable. From the person who's in the administrative side, I do not know how they're working about it, but like sir was mentioning, there are a lot of loopholes when, a lot of departments are concerned, because it becomes like it's your job and my job kind of thing. So there are certain provisions given for northeastern states, like normally to address applications and to register, we need 7 days. But smaller provisions that have been given is, they have been given a little more time to, again, reasons listed were geographical constraints, inavailability of adequate mental health resources. But if you look at it, the whole country does have inadequate resources, but because of geographic terrain, and then there are very less number of professionals to cater. So these are the small provisions that are made. So then we also have, I'll not be going under that, but supported admission, unsupported admission, what are the characteristics, how can a minor get admitted, so all of the mode of hospital procedures. So like again, within 21 days, we can file, we were, but because we were scarce in number, there were only 4 of us, so it's been handed over to counsellors. SLA says clinical psychologists should visit. The hospital says we do not have enough clinical psychologists. The ILHS, our counsellors are going there. Up till last year, I used to go. Okay, so this is again related to treatment, the discharge part of it. So emergency treatment. So here, this is a clause in which we can forcibly provide treatment to somebody based on certain grounds. When the person is planning or has expressed desire to take his own life or take somebody else's life. Like yesterday, the person, she was complaining about the suicidal ideation, so I had to ask her neighbor and her flatmate to take her to the emergency department. I could not sit and ask, okay, would you want to go, or do you think about it? Or I could not even call her to the OPD the next day to talk about it. One, that I have to come here, and 2, I would not know what would happen in those 8 hours. And then that's also why I called her, the person, the uncle, to talk about this, because again, being in a position, I think you would understand. I need to check now who's come and what has happened. So, पहिला चाहिँ suicide helplines, ma'am, sorry to cut you. त्यति बेला चाहिँ we did not have trained people who were actually handling the lines. They were only trained for a brief period. How sir was mentioning, CCI, the people who are working, they are very briefly trained, or they are just oriented, so it becomes difficult. What I see, a lot of people are using telemana specifically, and because you have adequately trained people, it's functioning. So normally you pacify the person. So normally it's an impulse. Right now you feel that it's too much and I'm not able to handle it, right? So when you talk through, you realize I've done that like at nights when my patient have called in the middle of the night, I have to be alert. But depending on what they say, sir, okay, so, okay, how can we look at it? Okay, suicide, I want to commit suicide, this is so. Okay, so let's talk about it. Since when have you been feeling like this? What do you think would change after that? So these are like, obviously I can't say commit now or another, and technically that is what I would want to say, but of course. So there's like, just a therapy now, we have questions, in which you can't directly ask, you cannot directly tell them what to do, but you go about understanding them, and mostly it is just the space that they need for somebody to listen to them. There are people who don't reach out, that becomes a major problem because it's just an impulse. If it's for a fraction of a second, or let's say for 10 seconds, 1 minute, if you're able to engage that person constructively and that person feels supported, most people abort. They would have had planned extensively. So this is a little different from people who've had suicidal thoughts or ideas, but it has not developed into an ideation. It has not developed to that level where then, they would have planned everything. So if you look at it, I would say yes, people reaching out, the number of people we see accessing telemarketers, the number of people coming to us, or even I would say WhatsApp is a boon that is at least people texting us, and then us getting back to them. But unfortunate is that while I was working on this presentation, one used to message Onik late today. She'd already ingested some substances, as in the medications that were given to her, but thankfully they were in a smaller amount, and medicine is taking care of her right now. Apparently, yes, sir. But one of the thing was that how do you phone, and especially when it is a girl on the other end. Okay, so so when we talk about emergency treatment, any registered medical practitioner, that means a medical officer, can treat, but they also have to take informed consent from the NR. When there's death, like I said, or irreversible harm to health, inflicting serious harm to himself or to others, and person causing damage to property, त्यति बेला चाहिँ हामीले फेरि उनीहरूलाई forced admission गर्नु मिल्छ. So this again basically talks about, टिभीमा देखाउँछ नि त्यो इलेक्ट्रिक करेन्ट लगाएर द्याट पर्सन जर्क्स त्यो जर्किङ मुभमेन्ट हुन्छ अन्त त्यो voltage will be decided on a protocol. तर पहिला that was not regulated. अहिले the modified ECT भन्छ, त्यसमा चाहिँ the person is given anesthesia before it, so the person does not go through it. So it helps with the electric stimulation of the brain. So basically, it's not for everybody, only for certain conditions. So electric current means, yeah, it does. For people for whom any other treatment has not worked, for somebody who's come with severe depression, with psychotic symptoms, and actively suicidal, that can be considered the first line of treatment because there's something called ketamine therapy also, if you're aware. So ketamine is considered a psychedelic drug. Medical practices when a person is highly suicidal or has symptoms which need to be brought down immediately, because for us the medication is not like Saridon, it doesn't work in 20-25 minutes, it takes 2 weeks for us to see that noticeable change. So in these cases, when the threat is severe, ketamine or ECT. Here in Manipal we had, hospital we do not have ECT, modified ECT. That I'm not aware, sir. Because that is not my part of the treatment. Sir? Okay. यहाँ STNM मा चाहिँ छैन, मणिपालमा चाहिँ थियो. तर हाम्रो हस्पिटलमा चाहिँ there are days आफ्नो युनिटको. Next time, sorry. I didn't want to go to that actually. But of course, it's not a nice thing. So after the recovery, once you're given the ECT, there is a bit of memory loss. You do not remember. Sometimes, after a couple of hours, you're able to remember, because obviously you're giving high voltage to the person's brain, right? And sometimes brief. What is that? Notice, because it is modified, so all of those have been taken into consideration. Paila ko it was random, like the voltage and then the way it was done. It was, people were not anesthetized, so it was more of a, I think, trauma to carry. It is all systematic. So before नै decide गर्छ को चाहिँ लिस्टमा ECT मा जान्छ, why that has to be clearly specified, duration, कति rest गर्नुपर्छ, and then the explanation like what is ECT and how it's done and what will happen. त्यो पेशेन्टलाई पेशेन्ट इन कन्डिसन छैन भने उनीहरूको फ्यामिली रिप्रेजेन्टेटिभ उनीहरूको एज इन युजली त इट्स अ फ्यामिली मेम्बर उनीहरूलाई गर्छ. बट हियर मणिपालमा चाहिँ के हो सर, एसटिएनमा वी डु नट ह्याभ. किटिमेन पनि वी ह्याभ मणिपालमा, यता चाहिँ लगाएको छैन. आई थिङ्क दे विल स्टार्ट. So I think government institution it becomes a little difficult to put in a lot of protocols, Reza, because there are a lot of things that you have to go through. In private hospitals, it's easier to set up things. By mistake, the thing no longer. By mistake, first of all, कसरी लाउँछ, it means an apparatus. आफै त्यो के भन्छ, लाइक बिजुलीको पोस्टमा झुन्ड्यो भने चाहिँ probably by mistake, but that will be to the whole body, not to them. अब normal personलाई गर्यो भने पनि better हुँदैन सर, the complications, the memory loss and all of that हुन्छ.
There might be cases because we deal with medical negligence cases also. They are totally by mistake कोही अरूले के गर्छ.
So far, I have not come across anybody because I mean it's not something we've ever discussed in the rarest of rare cases also.
So you have two takeaways. One is tripolar.
Tripolar and this. What will happen?
Before they put you said diagnosis and all. Is there any way or any method to know how convoluted, how depraved, how deadly some person mind?
There are ways, there are assessments, there are observations.
Non-verbal cues is much of
Because the observations and assessment now we get to get a lot of
medical or technical
a test. Psychiatry means we do not have any test which will help us determine okay, this is the diagnosis. Like if you get tested, I get tested, मेरो depression आयो, तपाईको schizophrenia आयो because of this marker भन्ने छैन. Genetic markers are there, and this whole genetic study actually would be a big boon because exactly कुन चाहिँ marker ले चाहिँ कुन चाहिँ illness छुटाउँछ, all of that research has been going on. They have identified certain genes which are responsible, and work is going on, but here clinical practice ma chai, I mean, it's all based on our observation, our interview, and sometimes if I report only half of my symptoms, obviously my diagnosis will be based on what you report. So which is why we always have to take information from multiple people. And this again is a problem in legal cases now because jab jail bada ल्याउँछ नि सब patients haru, the person in charge, I think from jail they pass it on to the police and police ले ल्याउँछ. So when we ask, उनीहरुलाई के पनि हिस्ट्री थाहा हुँदैन. ना त अब पेशेन्ट को फ्यामिली हुन्छ, उनीहरुलाई पनि थाहा हुँदैन. पेशेन्टले obviously will give you as per what his understanding is, and the jail authorities then they do not have. So I think this is the drawback, because if you have a psychiatric unit in the prison, then there would be qualified people to assess your mental illness, your mental recovery this. Like when I go, I check them once depending on the schedule that they have, we check them. So I cannot actually see 2 months, I cannot actively observe them. So that also becomes a challenge. Like a person had paranoid schizophrenia, paila treated, and then there was a crime, and then when that person was referred to us, I think this person had already spent about 8-9 months in the prison. When the person came, they came with an entire file of how this person was treated. And I had to certify whether the person currently has the illness or not and can be tried. So again, that assessment was only for that point of time. And the person was admitted to the psychiatry. Teti bela pani observations were that he was showing psychotic symptoms, but the test, the interview, and the observation did not match. So. I think we need to wind up because I'm sure it's past everybody's lunch. That's what somebody was suggesting just now. So we'll just be quick. Like I said, responsibilities of other agencies we discussed, and I don't think it quite pertains to us. There are like, so for example, one of the new change that is there. Paila, what we knew was when the police officer had got somebody who was mentally unwell, they would need the magistrate's order to come and get them admitted. And actually, if the person is found, then they need to get the person evaluated by a medical officer first. So there are provisions in which, yes, the magistrate can grant them treatment, like, treatment in the hospital, inpatient admission for 10 days or 30 days, and there are certain admission clauses to be fulfilled before that. But emergency treatment applies, and in most cases, like again, the homeless case discussed, so the person who did not have anywhere to go to. So in those cases, the police has to file an FIR. Bilaji, it was not mandated. Now the police has to file a missing persons report and then track the family and then hand them over. If in case they are not able to do so, then they have to assist in handing them over or the procedures to get them to a halfway home. We also have another presentation on mental illness, so I do not know how we go about it. So we'll try to be as quick as we can, because it's already, I'm not discussing the admission part of it because I don't think it would make sense here as in for this forum. So here, like I said, there is no involvement of the judiciary in either admission or discharge. Okay, so basically this is the protocol that is followed when a homeless person with mental illness is brought there. So yeah, so supposing here, I think the role of the magistrate comes in wherein if we feel the police or anybody who has felt or who has seen that a person with mental illness is being ill-treated or neglected, they can report to the police, and if it is the police officer, then they can report it to the magistrate. And magistrate can pass an order and then call them. So this is again with regard to admission. So one of the most important issues that this law has been applauded with is decriminalization of suicide. But we also need to remember here that the person is considered to be undergoing considerable stress to have attempted suicide. So if the police has proven otherwise, then they can go on with the legal measures. But not everybody who attempts suicide has legal angle to it or would be tried like it was previously. Now the 5,000 to 50,000 fine is for mental health establishments who are not registered or professionals, mental health professionals who practice in places which are not registered. So the fine is implied on the person who runs it and the people who are practicing. So yeah, this is the penalty that I was talking about, like how is it in the first contravention and how it is subsequent. Then we have other sections, which again we will not be covering because it's a huge one. So the provisions for northeastern and hill states is, like I said, with the geographical location. They can take more number of days to file the registration. They can take more number of days because most of the people, they visit bigger mental health institutions for admission. So in that, the duration of admission can be increased. So this is the decriminalization of suicide that I was talking about. And basic difference again is, like I said, in terminology. See, in psychology we have this concept that, everybody says, no, have positive affirmations, talk positive to yourself. The basic thing is that your brain construes information based on how you put it together, how you perceive it, and how you understand it. So if I think, oh, I'm a failure, I'm never good at things, I'm more likely to focus on the fact that it will not work, so my efforts will not be at par. So which is why whenever they say, oh, be positive and all of that, it basically means to put things in such a way that it appears more plausible. So if we look at, like I said, when we say somebody is schizophrenic, I think that is the word even most medical people use. So it is not schizophrenia, but to say a person with schizophrenia. Like how we are not saying mentally ill, we say people with mental illness. So previously, like I said, it was called asylum. A lot of people still use this term, mental asylum. Now it's mental health establishment or mental health hospitals for that matter. So there's a lot of difference in terminology which puts the rights of the person with mental illness at the forefront. And we discussed the modified MECT. Here MECT is ECT. MECT is modified ECT and it cannot be given to minors unless and until the specific case demands it, and there always has to be a justification to it. And the unlawful restraint example cleaning that we spoke about. So we were discussing like how the act is relevant and how it's not relevant, right? So here the good part of it is that it gives a lot of rights to the person with mental illness. Substance use disorder is also included because there are a lot of people who get into trouble or get into legal conflicts when they are intoxicated. So because it is an illness, that is how it has to be treated. So for example, if a police catches somebody who's under the substance, under the influence of substance, they're supposed to present the person to a medical officer first, and then only go about and then understand whether he's in a position to do that or not. So we assess the person on certain grounds, and after that only the report is filed. So this is the good part of the act, like I said. And provision of, like, certain procedures being banned, people with mental illness having the right to seek information, right to confidentiality, and also the good part of it, like we discussed, medical insurance being provided for them. And the demerits we already discussed. One, admission procedure becomes very tedious. Now in a hospital which already has lesser people, it becomes difficult. It is difficult to approach and find mental health review board to exactly function as the law says that we discussed. And the role of family members is not there, which plays a huge part because there are illnesses which get increased, exacerbated by the attitude of the family members. There are proven studies for this. So we also need to see that if we are involved in all of the paperwork, then the time to treat each patient is reduced, and then we do not have additional resources for that. So one of the major shortcomings that a lot of professionals have discussed is the fact that it will cost more to give mental health, and the state will not have the capacity to fulfill all the legislation or all the rules that have been identified. So yeah, another thing is, like we were discussing here, so as of, this is a 3-year back data, so only 19 states had implemented the act, and like I said, we only have about, now I think the number is 4,000 something, the number of psychiatrists available, and we only have 898 psychologists, clinical psychologists. So you can see the number of people who are required and the number of people who actually exist. There are people, but because of certain, I think, reasons or certain opportunities, most of them, like we call that the brain drain syndrome. No? A lot of people go and work outside because obviously it is much more organized than it's here. So okay, so I have a couple of slides which are for admission, so we do need to go through it. So we'll quickly go through the mental illness part of it. I'll try to be quick. If anybody has questions, then probably we can take it.
Archana, they are either hyperactive. Some of my family members, it's a basic hyper with autophagy. Either the movie is science, right? Is there any relation? I've asked
Research-wise, no.
Work on it. The third takeaway.
I wish I had the time to do that. I really don't, but yeah, astrological, I think you should seek the answer from an astrologer.
I have a driver who was deaf and dumb. A deaf and dumb driver was my private driver for almost 6 years.
You're deaf and dumb, I know, hearing and speech impaired one person. That is the correct term.
I stand corrected. I have to update myself.
Don't worry, we are also updating ourselves.
So he won't believe man. Other days he would be very dirty and cooperative. तो कोई की मेरा चाहे आखिर चौड़ ना पाने से कर। तब आखिर चौड़ ना बैठ के तो माती है पड़ती है। Please work on it.
Maybe you can you fund a research? I'm sure there'll be a lot of people who want to work on it if you fund it. The funding itself is a huge issue. Maybe when you get funds from there, then you can transfer to the department. Okay. So basically, I think we've had a lot of workshops, again, put forward by the SLSA for different departments, of course, with regard to mental health awareness, because it's become one of the most important things. So we say when we talk about health, a lot of people only think about physical health, but mental health is actually a very integral part of it. So our emotional, psychological and social well-being, how we think, feel and act is all determined by our capacity to understand, withstand stress, how we relate to others, how we make choices. And it is not just whether a person is mentally ill or not mentally ill. Like all of us, I'm sure, if I ask and if you answer honestly, there are a lot of people who have a lot of ongoing stress or have been stressed and had breakdowns then. So this is the reason why a lot of stress management workshops are ongoing, and I think you also have a lot of these people making money being all life coach and guidance coach and all. And the funny thing is that I realize now that it's branched out so much. You have a life coach only for financial matters. You have a life coach only for people who have legal issues. So I would think it's a big business because now you can actually do a lot of work, and I think that has only come about after a lot of awareness. The fact that mental health matters a lot. So when you talk about literacy, just learning how to read and write is considered as literacy, but that is not education. So like that, just understanding that you have mental health issues and you don't have mental health issues, that's not a part of it. Literacy has to be able to decide that how we fare, what we think, how we behave and how we act, and not just that, having a mental illness or not having a mental illness is a part of it. Okay, so now 792 people, as per the 2017 records, were had a mental health disorder. Roughly, I think now the figure is about 10.7, but it had inflated a lot during that 20 to 22 period, the COVID period. It was almost 3 times more. Obviously, with things settling down, a lot of people took treatment and got better. But it also reminds us of how fragile mental health is. That when there is a calamity, when there's a stressor, when there's a pandemic, there were a lot of people who required help. Of course, much more than what we could accommodate. 7.5% of the Indian population. Right now, the figure stands at about 10.2%. So when we say that 10.2% of the population has some form of mental disorder, and if this law were to take care of it, the budget that would be spent on this, providing free services, all the issues that we talked about, would be immense. So for our country now, we also need to understand that all of this Mental Health Law Act is based on what is followed in the Western countries, wherein the allocation of the budget to the health department itself is huge. So for us, we have, I think, 1% of the national budget being allocated to health, lesser than Sri Lanka and Bangladesh even. And from that, I think a very, very meager amount is given to mental health. So obviously, we do not have the resources. Okay, so like I said, the figures have doubled. If you look at the researches now, it is alarming. Like I'm working with children for my research. So if you look at it, the number of people, like number of children in between, let's say 6 to 10 years, the amount of stress that they experience or the kind of problems that they come with is itself much more. Like we get to hear, nani like depression ke ko huntyo, school padne ama baule sabai garcha ke ko depression ke ko anxiety bhanera. But maybe when we sit on the other side of the table, we know the number of children, the number of adolescents that are pouring in. And as per the last mental health survey, around 72 to 90% do not have access to treatment, are in need of treatment and have not sought help. So that's the gap, that's the huge gap that we have. Okay, so this is just... so now a lot of people ask, mental illness, now there are a lot of reasons, okay? So biological, obviously there is a problem with your hormones, your neurotransmitters, okay? You have head injury, a person who's functioning well and they have head injury, they have not been able to do anything for themselves. There are people who have aggressive impulses after head injury and they need some time, somebody long term to take care of them. Epilepsy, neurological conditions, okay? Psychological, I think most of us have seen that. Life trauma, abuse of sorts, history of abuse, domestic violence for that matter. A lot of people who've experienced them, even bullying for that matter. A study says that a majority of the people who have been victims of bullying become bullied themselves. Now, of course, there are a lot of reasons as to see why the victim became the perpetrator, but even for alcohol disorders, if you see, a lot of people who have had parents with alcohol disorders, alcohol dependence, they also become dependent. So genetically also you're predisposed. That would be the biological part of it. The psychological part of it is the subjective experience you had to live with, the amount of support you got, whether you were able to resolve that or not. Now, other chronic mental,
Bullying children में होते हैं.
I'm sure it happens in offices also.
Yes.
I think it happens more in offices now.
Yes. Please continue.
So, and maybe when it happens, I can ask you to draft. So, experiences related to. I think you wanted to volunteer, you wanted to ask me to draft, so experiences related to other ongoing conditions, for example, people having long-term illnesses, cancer, tumors, use of substance and alcohol, which is always there, and I think one of the biggest problem. I think the last census, we are one of the 5 states in which substance use is the highest number of women with use of substances. I think the third when it comes to people who use other forms of drugs. So we have actually, yes. So the way we have progressed, not only otherwise but also in substances.
Women with drugs are in very high positions. Let me tell you. It's only that waiting for someone to take it.
So again, funding research.
As you said, there are very less people who come to you. You know the symptoms. Take for example, or people like in our position speak to children should not be listed. That because I even have taken medicine for depression, but I had acute depression. So for me to understand the symptoms, it took years. I was having other ailments like gastric, sometimes dizziness. I went to the just all the doctors. They said you are perfectly fine. In the end, I went to a psychiatrist. He told it's just a chemical. I saw that board. You prescribe medicine. I took 3 months and I had actually said I should go to 1 year. So how do you know the symptoms? I went to different doctors. So for an educated person like me to diagnose that, I really have to do it. So I should know it instead of. I went to several doctors, other doctors, general physician, cardiologist, everyone, ENT. They did all the tests. I was perfectly okay. So when I went to other doctors, they must leave me I have having a mental problem. In fact, I told one of the doctors, it could be a mental health problem. He dismissed it. A doctor dismissed it. Some other specialty. So
They must have thought of a Dutch Saru. No, allowed.
no, I didn't tell them that. Sometimes I told them because so to some I told lawyers.
Chettri ma'am.
How do you know this?
Can I answer this question first off, please? So, yeah, sure. So,
We have to work with judicial officers here to rule acid depression.
frankly, we have a lot of people working in and around Sikkim who we feel like, hey, I know that depression can like that, because that's the common conception. But we do have a lot of people, and in the last 3 years, or let's say 5 years, I've seen actually a lot of people walking, like how you said. The question to your answer is awareness. Because we are not aware. See, because Buri Dukhe was the first and a gastric collar, like you said, right?
Doctors,
Yeah.
the doctors, they could have said me after getting the symptoms.
No, because for a psychiatric disorder itself, we need to rule out the physical illnesses first. So if I have a problem with my mood and I go to the doctor and say I'm positive I have depression because I've read the signs and this is what it is, I still need to get my biological parameters checked because hormones can play a role in how your symptoms are interpreted. So getting angry, okay, can also be because of your thyroid elevation in your thyroid symptoms. If let's say a lot of people who have mood disturbances during pregnancy, again the hormone disruption part of it. So there are a lot of biological parameters that need to be ruled out before the person is sent. However, if you are aware as a clinician, then it is easy for you to check. We've had patients who have been on cardio medications for 10 years, 15 years. When the cardiologist, I don't know, for whatever reason, patient ke body na ki doctor le jane, I don't know, that they have not sought treatment. And after 15 years, we realize it is a panic attack, a panic problem, something to do with anxiety or somatoform. But they would have eventually, like you said, unwillingly gone through 110 people to actually come to the place where they need to be treated.
Probably from my experience, I think I lived with that for about 12 years, but it aggravated. At one fine day, I couldn't tolerate it. I till my symptoms, the last 2 times I had, my mind was okay.
Exactly.
medicines, that's mine.
Mhm.
And I see so many people like that. But I can see those symptoms in them and I address them, but they still do not want to go to psychiatry.
That's what, no, the
Doctors
stigma
feel
part of it, sir.
the stomach are aching, but believe me, after that medicine, my stomach ache, everything will go.
Because those are what we call somatic signs. So when your brain is ill, it does not just show in your um, ability to get in touch with reality. If you आवाज सुन्छ मान्छेसँग एक्लै बोल्छ, that is part of a severe mental illness. The तपाईँले जुन चाहिँ symptomsहरू भन्नुहुँदैछ, that is more of your somatic symptoms. So when your mind needs help, it sends, let's say, to put it very simply, signs through your body. So घडी fever आयो, for example, can be stress induced. Stress area, when if you look at that, body aches, Archana duksa, bulika duksa, unexplained. So even after your vitamin levels are checked, even after all your parameters are checked, so probably you ended up last because all of that took time. But if we are aware, then सँगै checkup गर्नु जानु. Now there are a lot of people जो हाम्रोमा first आउँछ and then we send them for evaluation. Thankfully now the coin is turning. I just thought you wanted to ask something, sir.
4:30 p.m. I normally I have to take a nap after 4:30 p.m. After that I exercise. त्यो nap लिएर जब म उठ्छु केही गर्नै मन पर्दैन. Is it a sign of depression कि laziness कि?
So 4:30 सम्म त you are functional, right?
4:30 super computer. But the moment I wake up after my 30 minutes or 30 minutes को half an hour को evening siesta के भन्छ nap. एकदम दुनिया कसरी फोन आइरहेको उठाउनु मन पर्दैन. एक्सर्साइजहरू कसरी गर्न अल्छी लाग्छ.
I wouldn't call that alchipon or depression. Maybe it's got to do with a lot of how your day has gone and what is going on. And I think you need to sit and think what has been happening in and around your life, in your life that may be causing you to take a back seat from your everyday. So stress probably which has not just so come to a level where it needs clinical attention, but it's building up. So which is why the big energy levels and motivation is getting affected. One, get your bloodstream first, because we need to see the vitamin levels chart. That would explain your vitamin D also explains your mood and your fatigue. Okay, your magnesium levels also look at how the sleep pattern activate the quality of your sleep. Okay, and then once your blood parameters are fine, then I think you need to come to us for stress counseling. If we find something, or if not, if we find bigger things like you said, the initiation of depression, because depression is not like what they show in the movies. So I think the lifestyle changes, habit changes, and your work environment, like you said. The kind of cases that you see. I think you need to come down. I'll take 2 hours with you and exactly tell you what's wrong with you. Okay, the social causes of it, like let's say the kind of environment you live in, the kind of housing you live in, the kind of people you have access to, the kind of facilities you get, all of that also have a lot of impact on our mental health. Sorry about that. So feeling unusually confused, sometimes forgetful. So if you look at it, yes, there are a lot of things which are normal, but sometimes when we overread the symptoms, and then you start digging more, and then again your best friend, your WebMD and your Google only make things more complicated. Because if you look at it, if I say I am tired, there will be 110 illnesses which will fit the profile. So sometimes overreading or over-identification is also a problem. Having frequent tiffs with friends, issues like Sir was mentioning that, crying. Sometimes for reasons, yes, you cry, but sometimes for reasons that are very trivial, or you feel that you did not need it. Like, people say, I am, before that person, I am the one who tears up first. So not having emotional regulation. Those are also one of the warning signs of, especially neurotic disorders, like anxiety and depression. These are the signs we see first. Having persistent thought and memories you can't get out of your head, so overthinking, and if somebody has gone through, trauma, more towards the physical sexual trauma, then you do have what we call PTSD, wherein these thoughts and memories keep coming back to your head and your normal functioning is impaired. Hearing voices or believing things that are not true, I'm sure you would have heard that in your courts. That is why it happens.
Last 3 symptoms which I could not tolerate was because the table it used to float,
Mm-hmm.
and the ground used to be very soft. I had a cushion.
Mm-hmm.
The third one was I used to feel someone is pushing me from here. I
Mm-hmm.
used to literally hold on to it.
Mm-hmm.
No, no, I went to psychiatry. Everything gone.
Mm-hmm.
After I took that medication.
So then your levels of severity at that point
This matter.
was so much that kabele bottom up. Depression and usually these signs are only there when it's more extreme.
When I look back, I think within 26 years, instead of doing once a psychiatry.
So capacity, usually like we say, no, stress we don't get stressed. Our body gets adjusted to it and we bear it until it is above that clinical level. If you assess, all of us have stress at some point or other, and if you really screen ourselves, all of us will have some scores. But when it becomes unmanageable, so we say that a person has a disorder only if they are socially and occupationally impairments of functioning man, which is what happened to you. As long as it was minor and you were handling it, things were better. So it happens with us also. When there's too much of caseload, sometimes you switch off between cases, right? Which is why again the boundaries that we spoke about, the workload, the work environment, all of those impact us in ways which we wouldn't have normally thought about.
And after that, I met many people who have this symptom, they are taking these medicines. They're still taking.
Okay. Yes. The reason why your psychiatrist must have asked you to take 1 year of medication is
I took only 3 months.
3 months. See, 3 months, if you look at it, 1 month, some symptoms will come down. Okay, but the first episode, the treatment cancer, that is considered to be the most crucial. So if you complete your treatment, then the recurrence of the problem becomes lesser. So which is why the safer period is 6 months to 1 year.
There was one small medicine which I was advised to take only if I
SOS
really require it. And the moment I think it's good to take it, I didn't take it much of twice a time. The whole body seemed to be so nice.
Clonazepam.
I don't know what it is.
Clonazepam 0.25, yeah. Because that will suppress all your anxieties and your fears, and you will think, okay, I can handle
Fine.
things.
The word looks so fine.
Yeah, and as soon the medication co-effect wears off, again the world is back.
But I took only that.
Yeah, so SOS not the danger. So only in some cases that is a regular part of treatment, but it can be habit forming, which is why it is reduced over time. I do not know the medications that you are taking, but like for some people it takes only 2 weeks, 1 month. We have people who've only had medication for 1 month and gone, and we've had those people come back later. So the general rule of treatment is that the first episode should always be treated fully. So even though, let's say after 3 months the symptoms the medication would be reduced to a minimum dose, and it would be continued for a time until we are sure that the symptoms back on the. So that waiting period is usually about 3 months to 6 months, and in first cases severity, so that is like a year. That's a safe period.
I feel I should have taken it for 1 year. I myself stopped, never went to this doctor.
No, the antibiotic thing. So antibiotic we didn't stop person, and then we feel we are wrong. And next time the antibiotic doesn't work. The worst part is psychiatric disorders for treatment we have very limited drugs. So when we do not take the complete treatment, the next time that drug may not work for you. So we'll be left with one less option. That is also the reason why the completion is important. Symptoms, obviously the hearing of voices that we're talking about, no? The antipsychotic 4-5 din it will come down.
Sometimes it does occur, but now I've understood it, so I can handle this one.
Yes.
Oh, is this the at the very moment when I think this happens, it goes away. Previously,
That's where your knowledge, your awareness helps. So pharmacologically, treat करता. Psychologically, for us, therapy is understanding the illness, knowing how to deal with it, knowing that it is time limited, being able to do something. So basically, we equip people to handle their illnesses, because obviously there's no guarantee that right? But next time, like you said, when you're having the warning signs, you can always work on it before it gets to that level where you have to either get hospitalized or take more severe treatment.
As a clinical psychologist, you can also become a medicine.
No, our roles are different. Medication is psychiatrist prescribed. Dr. Laspa is a clinical psychologist. Yes. Okay. Okay, I think so was talking about it. So when we stress, now stress doesn't mean that office को stress, this stress. When your body is not able to tolerate what is happening, either in your head, in and around the environment, or in whatever context, the signs headaches, muscular tension, breathlessness, not being irritable, finding faults in smaller things, not being able to concentrate, taking impulsive decisions, not thinking things through, your loss of sex drive, drinking more, sleeplessness, restlessness, all of these come in. So these are also signs we need to look for, which means your body is giving you a sign that something is not right, fix it. Symptoms of depression, we'll deal only with the first few slides because these are more fun to look at and more easier to comprehend. Feeling of sadness, guilt or helplessness. If you look at it, a lot of people also don't come to the OPD because they have severe depression symptoms in terms of crying spells, ekle bossa or okay kam gardan. It is also more to do with guilt. For every small thing they do, they feel very guilty about it and they are unable to function. Loss of interest in activities, your inconfidence or not believing that you have enough worth, excessive or sleeping less, like manchele bhaन्छन् depression ma ta मान्छे सुत्दैन त कसरी यति बेसी सुतेको भन्छ नि. So a typical depression ma that happens, like depression हुँदा मान्छेले खाना खाँदैन, वेट को घट्छ त कसरी मोटा हुन्छ भन्छ. But a typical depression ma that also happens. So there are always exceptions to the rule, we need to consider that. Digestive problems, one of the biggest thing, and more than depression, it shows up in anxiety. More than half the people who have digestive issues also have an underlying anxiety condition to it. Mostly when you go to gastros, they will give you something for your gastro symptoms without asking you to evaluate your anxiety. So then this is more of a common problem.
And these days, you must have noted, mostly couple people are looking at
Stress does affect, but then there are more other biological variants to it. I mean, culturally, if you don't have a child with somebody, you'll marry somebody else. So the IVF, whether it's a problem with the person in the marriage, male, female, because they are diagnostic measures, like somebody may have a okay tubes, but then your uterus may not be able to support. So biological reasons first, but yes, IVF treatment ma pani, stress management is a part of it, and they do send you for active counseling because the process itself is very stressful. And yeah, the rates have increased. Maybe also because now we know there is a problem and we seek help. Even I didn't bakal rakcha, bako chaina, ke boy family, all of those things. Maybe because there was no explainable answer to it. Logic come we would depend more on other things. Physical aches, like I said, trouble focusing and making decisions, restlessness, irritability, and suicidal thoughts and attempts. Depression but when it is there, that is more of it qualifies more for a severe category.
Does it include muscle twitching as
well? Muscle twitching, it's more of a symptom rather than the symptom. If you notice that the muscle twitch okay, and if you really look at it, it happens more if you notice it. Okay, and then if you can catch the situations and you can assess yourself whether it's stress related or not. It is not a sign of anxiety, but for people who have an anxiety attack, they have reported symptoms. And again, there are about 40-50 signs of anxiety. All of us who qualify for anxiety may not have it. I may have 5 or 6, or people have a lot, like just not knowing where you are, so derealization, so all of that also happens, but more in extreme cases. So tapeko is a smaller symptom, it's definitely there as a problem, but we don't know related to what. It can be a medical problem, it can also be a psychological problem. So I'm sure when you read this, you are like confused because there's so much, right? So this is what happens in a person's mind towards anxiety. It's constantly running and your head is so full that even when you want to stop, you can't stop. So this, like when it's lesser, you're able to take care of it, but when it's not, then it becomes too chaotic, and that's also when you need help. And anxiety is more in females than in males as per the global criteria, but if you look at Sikkim in the last 15 years, I've seen more males with anxiety than females. Now I don't know what is the reason behind it, but we have more younger males coming in with anxiety than females. So this all lightheaded, headaches. So it is to be like perfectly so if I am not prepared to your court, I'll either come and say कि म prepared I'll make up some reason and then I'll not be there. So if you are good to me and if तपाईले मलाई एउटा सानो bad कुरा भन्यो भने, no, then for me it is if I was good to him, then उसले चाहिँ मलाई नराम्रो कुरा भनेको थिएन.
as a
Mm-hmm.
either everything or nothing.
Yes.
I should think it that way.
Example.
Perfectionist.
Perfectionist,
Yes.
yeah, perfectionistic or perfectionism will be one contributing factor. So if you don't have anxiety, if you don't have depression, that perfectionism may also be there as a personality trait. So त्यो malfunction जब गर्छ, then whether it will become a problem or not आउँछ. There are a lot of people who have subclinical anxiety and perfectionists whether they are managing. Because when you say you are a perfectionist, you will make sure that you will think of every possible problem that can occur and you will be prepared with every possible answer to it, right? So you save yourself from anxiety and you think it's really smart and this is what I need to do, but you are actually overworking yourself because obviously everything cannot be at control all the time. So panic attacks, I think that's one thing, that feeling breathless, सास फेर्न सकेन, घाँटीमा के अड्केको जस्तो लाग्यो. This is one of the most common problems that we especially in younger people. So then again, anxiety disorders can be different. Excessive fear, खुन देख्यो भने फेन्ट हुन्छ, हस्पिटल जानु सक्दैन, इन्जेक्सन लागेर डरले फेन्ट हुन्छ, all of those would come under phobia. So see, fear and phobia are different. Fear is what you're scared of doing, but phobia is something which you cannot tolerate at all. So in terms of degree, they are different. OCD, a lot of people, again, I think we are so, I don't know, over-identifying or whatever. A lot of people say, I'm depressed too. And the OCD is also okay, you know. Now, if you really look at it, there's a criteria for each disorder. Just because you are spick and span and page sida chahincha, like bango rakhnu, then it does not mean you have OCD. So, you know, there's a certain criteria, and when we use that term very loosely, you also bring about a lot of problem because you start reinforcing yourself. मलाई यो problem रहेछ, मलाई depression भएको रहेछ. So if I don't do something, depression गर्दा न त गर्नु सक्दैन. You don't actually look into it. You make it your crutch. Mixed anxiety and depressive disorder, wherein anxiety and depression are together. Social phobia, fear of public speaking, not being able to go out in a crowd, बजार जानु सक्दैन, functions जानु सक्दैन, fear to use public toilets, fear of flying, all of that, heights, यिनीहरू commonly उयो गरेको सुनेको. We had a patient, you know, who had this fear that he would get an HIV transmission. काहीँबाट मलाई HIV हुन्छ, that was his thought. And then, yeah, he would be so scared that he would be vigilant कि दोकानमा you check उसको helpers को hand अलिकति prick छ कि छैन. You would not allow people to touch. Now every day the दोकानमा पनि like, you know, gloves लगाएर बस्न सक्दैन नि. But for him, he was so particular. Eventually, he closed down his shop for that period when he was absolutely unwell. Coming to the hospital also, he'd feel like that. We have people with OCD who don't get into taxis because taxis मा त्यो handle अर्काले पक्रेको हुन्छ, पक्रिनु पर्छ, and doors खोल्दैन. So they'll wait until somebody opens the door and they can just go in. So you know, I mean, movies हरूमा देख्दा त we feel अफि यसो, and to an extent we get amused also, no? अब त्यो काँटा चम्ची टक्कै मिलाएर राखिराको सबै त्यो, you know, we have च्यादर ओछ्यानको बेडसिट लाउँदाखेरि all of that line match गर्नुपर्छ, all of that. Those are smaller issues which don't quite make so much of a problem in everyday life. But imagine my patient would always be half an hour late to therapy because he would have checked his car 100 times because he would feel that lock gareko chaina. He would walk, then again go back, again check lock gareko cha ki chaina. So you know, I mean, every day. So you doing it once in a while, it's okay. People returning halfway, checking their lights. People thinking that, oh my God, I missed a signal, and then being worried the whole day. And then, you know, the more severe type or more sexual obsessions and blasphemous obsessions, just magic. You don't want to, but when you look at a person, you will only relate to them sexually. You will think about them and the sexual fantasies with them. And this may even be a family member. That is much more distressing.
I think that thoughts of sex with it already, you have to rephrase it.
Which one? Yeah.
Thoughts of sex with it, thoughts of intimacy, thoughts of intimacy, over obsessed with sex with it.
No, not necessarily. Obsessed with sex would be more of sex addiction. Thoughts of sex is like if you're walking, let's say, and then there's a random stranger, okay, or you want to have sex with everybody who's walking. Now you don't want to, but that is a thought in your head. So it is not you wanting to have sex, or it is not your obsession. It is that you, in your head, it says, okay, you know, you put that person in that perspective. So that is disturbing. Objectifying, but everybody objectifies would not have OCD. I think they have more problems.
I have a question. Academic question. If there's a person, like you said, there was a shopkeeper who closed down his shop because he was not feeling well mentally. He had that option of closing down his shop. What about working professionals who have to go to their work daily on a daily basis, like doctors
you have the right to decide what you would want to close with your employer, but if you are expecting to get levy based on that, then of course there has to be a filing, like you have to report and you have to get it back. Okay, now we have a surgeon who has bouts of illnesses wherein he is not at the position to function. So even though he is a qualified surgeon, he has not been granted the permission to do extensive surgeries. He can be there in the team, but his decision, especially, I mean, of course, you can figure out when the person is ill, right? So his opinion at that point of time is not taken into consideration. So they'd be doing more of, let's say, like they can seek transfer to places where they can just see OP demand. They do not have to do surgery, you know. So those provisions are made because unarko mental illness is known and we know the repercussions it can have. So you have to say भनेर त law छैन, because a lot of discrimination also happens irrespective of whatever law we teach and whatever goes on media ma. There is a lot of discrimination in the workplace. People have this misconception that mental illness ले त के गर्नु सक्दैन खालके. That mental illness, it's just one part of it. Yes, I may not be able to function absolutely at the apex, at the topmost, but I'll be able to do my basics. So that again depends on tapeko capacity, how much that has been brought down. Now for this person, the surgeon that we're talking about, one of the we cannot trust with somebody else's organ, right? Whatever like. त्यही कारण चाहिँ उहाँ उहाँले ओपिडी हेर्नुहुन्छ हो, तर उहाँले सर्जरीमा पार्ट लिनु हुँदैन. We have professionals, secretaries, lawyers, judges, different teachers, during that period of illness, they are refrained from their duties, but the school knows. Like we have teachers being brought in, teachers that admin jobs in Turkey, lower classes in Turkey, so that adjustment is there. But then again, I think only when we have awareness and empathy towards the other person, rather than discrimination and humiliation, then only I think these workfare policies can happen. Obviously, outside, if you look at it, courses that are applied or they have this criteria wherein if you've had depression, if you have anxiety and you're on medication, you will get that disability benefit. You will have criteria wherein you can apply with lesser.
So there's a psychic evaluation that is conducted overseas, not here.
No, here we do it. What I'm saying is, here, have you looked at any universities which have consideration for people who have illness? Most of them, there are people engineering but drop out गर्नु लगाएको. It's not that the person may not function, but yes, certain kinds of illnesses, stress will exacerbate the symptoms so much that that person becomes dysfunctional. So helping him choose a career which will be fruitful and non-stressful for the person so that the illness is maintained, that can be done. But yes, for that evaluation, and like I said, functioning, tapeko pailako functioning, pre-illness and post-illness, and tapeko capacity, currently cognitive capacity, all of that evaluation ko baadma chahi we can certify what are the kind of tasks that you can do, what kind of responsibilities cannot be given to you. But a periodic assessment, it's not like a one-time thing.
Whether the person is fit to work.
Yeah, and then yes, fit to work, fit to work in what capacity? Then continue treatment, because I mean, if you look at it, it's beneficial. No, a lot of people are taking that. Ma'am, I depression, leave like this now. Ma'am, I stress, and they do that when come basis. That is the human brain, to be very honest. So yeah, there are issues like that. Okay. So schizophrenia, I think court must say basically schizophrenia, psychotic symptoms. Basically, psychotic symptoms are not being in touch with reality. Hearing things hearing a voice which is not there, seeing things that are not there, believing things that are not there. When I was bachelor's, that was the first time when I came to a mental hospital, internship ko lagi. There was one person who I'll always remember, he used to say ki mero yo pati ko dimag khali tha because somebody is stealing. Bistaro every day mero brain lanta. And then you get on news and you think, but then that person believed it. Okay, and then he kept saying, mero adi mate brain tha. So I can only think, there's no thinking from one side of the brain or the other side of the brain, but he'd say, mo etta ko brain le mate kaam garnu sakchu because etta khali tha. So things like that. I was telling a lawyer about it, we were discussing that there's nobody who has not seen him.
I am the judge who gave the judgment. Just for information, read grandfather grandson पुरा मिल्ने. They were very close.
I've seen him.
अचानक एक दिन कि एउटा अब म्यासेज हो कि क्याच मारे अचानक. No previous history of discord थियो हैन. सो मैले यसो हेरेँ यङ मान्छे देहरादुनमा पढ्दै थिएँ सर हैन. देहरादुनमा पढ्दै गरेको यङ मान्छे अचानक आफ्नो यस्तो क्लोज ग्रान्डफादरलाई मारेर he did not even run. He wouldn't even try to hide what he did. अरू आउँदा पनि he was there स्टेजमै बसेर सिडीमै बसेर बसिबस्छु. त मैले I did of course being me atypical me अरू तपाईँले what is it atypical me. I researched. I acquitted him on yay ground. The Honorable High Court in its wisdom a division bench set aside my judgment. Convicted him.
He was there, Mati jail mass.
Matter went and appealed to the Supreme Court. And as it usually happens, मेरो appeal भयो. त्यो केसमा फर्स्ट टाइम मैले the severity कस्तो चाहिँ डरलाग्दो हुँदो रहेछ मैले त्यो केस पढेँ. प्र्याक्टिकली लाइफ चाहिँ मैले यहाँ देखेँ. बट नट लाइफ.
Could see how it would affect.
यो एकदमै डरलाग्दो प्रब्लम रहेछ है.
There are a lot of people who are faking it also. So their eyes are maybe a little awkward and both the real world, let's say.
So they have त्यसलाई मार and they have
We had a case recently, I don't know, I'm sorry, I do not remember, coach judge हुनुहुन्थ्यो, and when that person came, again, he gave me half the history, jailमा पनि हेरेको and hospitalमा पनि, I think around middle age of 50 something, male, comes from a lower socioeconomic strata, agricultural laborer, lives on somebody else's land and all of that, त्यो उनीहरूलाई त्यो ठेका दिन्छ something like that, and उहाँले चाहिँ he killed his nephew, he just hacked him. And this was a 18-20-year-old boy, and he was very close to that person. Okay, and then he told me the only that story that चाहिँ उयो थियो के भन्छ मेरो कानमा आवाज आयो कि यसलाई मार भनेर. So he was disturbed. So he heard. So that is your auditory hallucination. What we say. He heard that यो मान्छेलाई चाहिँ मार, and the voices are so loud and so believable that you actually end up doing what they say. And he saw that उसको nephew later was coming with a weapon to kill him. He felt that he was going to attack him, so before that he attacked him. This person had a history of 20 years of schizophrenia. He was under treatment, but I think the problem was उसको proxy medicine दिँदै थियो रहेछ, उसको family ले चाहिँ गएर medicine दिँदै थियो रहेछ. Now there was nobody to check whether उसले खाएको थिएन. There are people जो medication मा पनि relapse हुन सक्छ. You know that again is like what do you say? A drawback. There are people who can have symptoms even with medication. So उनीहरूको medication change गर्नुपर्छ, review गर्नुपर्छ, right? So उसको लागि I am dead sure he was not having his medication for some time. They did not have records to produce, but he had been seen previously. Now unfortunately, because we live in a small place, we know अर्का कसले हेरेको छ कसले हेरेको छैन. So like that उहाँको हेर्ने psychiatrist चाहिँ हुनुहुन्थेन, बित्नु भएको थियो. So उहाँको records त्यो hospitalमा छ, somewhere राबोङला or somewhere hospitalमा छ भने त्यहाँ पनि we could not access. But then at that point of time when he was sent to me, when we assessed him, he had active psychotic symptoms. So Dr. Vibhushan was seeing him, he was on medication, jailmai थियो, and when I was discussing the case with him, so you know, I mean, when you look at him, you wouldn't know he's disturbed because he looked absolutely calm, composed, and he would be like, Madam, or मलाई जानु दिनुस् न घर, so like normal मान्छे जस्तो काम बन्नुहुन्थ्यो. He would ask before sitting. So basically he was aware of what is happening. But this was when, I think about a month or 2 months after supervised medication. At that point of time when he was brought in, he also didn't run away, he hacked his nephew and he was just sitting there. And अरू मान्छेले बोलाको. I think there was another case, Chisma, I don't remember the person's name, but somebody had murdered and they had taken up the organs, they were playing with the intestine, nikaleko. So this also was the case we were discussing. And this repeated offender, again, I cannot take the name, but we've had one person who's seen by every psychiatrist in Sikkim, admitted multiple times, acquitted multiple times. So now it's almost become like a cat and mouse game for him. The police catch him for a crime, report him, bring him, take him to jail, he gets acquitted. So, you know, we were discussing this concept of Bairatira, you have supervised homes, no? A transition between, they are not fit to live in the society, but at the same time, they are not fit to be in the jail. So there has to be a transition home but we do not have that. So we even discussed with Justice Meenakshi ma'am, and then and I think she's very interested in mental health, so we used a lot of discussion. She always said that there are so many things we need to do, but we're not able to do. Now the question was, whenever this person was acquitted, he would go back. For 6 months, a year, he'd lie low, then फेरि आउँथ्यो. So people were like, everybody knew him, hospital mein everybody, police mein everybody, like फेरि पक्रियो. That was the kind of image.
Someone who go back immediately. I know one person.
Yeah. So हाम्रो कन्टेक्स्टमा के छ यस्तो रिहाबमा I know one person, a doctor who was admitted, not here. For 1 year, he was like a top doctor, Maldives or somewhere, and then 1 year बस्यो. So the entire year मा उसको feedback, उसको reports from all of us, from a psychiatric social worker, from a therapist, from a psychiatrist, was all clear. And then we had the system of parole जस्तै नि, we would send them out for a few days, then observe उनीहरूको reaction, see how they settle back in the rehab, and then again for a few more days यस्तो गरेर पठाउँथ्यो, which does not happen here. So the day he stepped out after a year, that day he drank, and then again we had to bring back, and he was the least person who anybody would have bet that he would relapse. So cases. So this one is smart. For 1 year he'll lay low, and then again he'll come. Our assumption is that there are some people who are very sensitive to cannabis. A lot of people smoke cannabis. Not every time something goes wrong, but for him, the minute he smokes cannabis, his psychotic symptoms come back. Yes. Yeah.
He was never treated since those days.
He was acquitted.
He became adult man.
Yes.
And I have there are 2 cases of him as adult also. I think still as well.
Yes. Now the same person that you're talking about. 5. I think 5. I have assessed him 3 times.
In one case, he escaped. He was being taken back to jail. He escaped and he landed up in the jail. I was registered 2 years back. He said, I get bored at jail, so I come. So I keep him there and secretly tell the police that the person has come. It's quite 2 years back.
It's been, I think, over 2 years because we also haven't seen him in the OPD. But this is a repeated.
You as an expert, can you figure out or make out, find out if somebody is faking it?
I think
as you said, somebody was faking it. It's all possible.
So हेर्दा त यस्तो हैन, but in the course of your evaluation, like I said, your clinical interview.
Medical history देखाइराको छ.
Then they are always based on medical history भन्छ पेपरमा लेखेको छ. Now if you tell me the history मैले त्यो पेपरमा लेख्छु so अर्को मान्छेले पढ्दा त they'll believe it, हैन? But that's cross verification, no? Just the law cases on the we cross verify, right? So like that we have assessments to prove. So if I'm saying I'm hearing voices, then that also has to be consistent. Tapele bhako person in question, me and my other therapist, we sat and we had such a long session with him. He said, I know, ma'am, I was because he could not defend his symptoms because we were cross-questioning and we were so interested because people would be generally like, and they would leave him and his symptoms would increase because he wanted attention from them. We gave him so much of attention, so much of detail in case, then he'd be like, I know, ma'am, I was jail for time, okay,
I had to just get out from him because I couldn't treat him. So jail
he was the one I think who was he was trying to attack everybody jail ma.
He was also chronic accused, so he was again taken for attempt to murder. In the same day, he confessed.
So when हामीले उसको नाम भन्दा ऊ फेरि आइपुग्यो, it's like he's become a familiar face to all of us and there's nobody who's not assessed him. So this symptoms of schizophrenia we're talking about. So most of us know about positive, symptoms. कसले मार भन्यो, कानमा आवाज सुन्यो, कि you see somebody, and you keep talking to that person, or you like I'll ask you something and you talk about something else altogether, and you will not be able to figure out. Like I'll invent new words and talk to you, and you will not be able to make sense of what I'm saying. Okay. So those are the positive symptoms. And catatonia, I think catatonia, the most of you would have seen in movies, no? एउटा particular position मा अड्केर बसेको हुन्छ. So if like the person is holding his hand up like that, normally the मान्छेको hand tired, we bring it down. That person in a stupor can stay for hours like that. Okay? So these are more severe forms. We have what we call negative symptoms. Junje is there will be no affect. When you talk about something, there is no change in the person's behavior, tone, in his feelings, the way he expresses. A motivation, not being able to do anything at all. Manchile but then they actually lack motivation. That is a problem, that is not like a trait, a behavioral thing. Not being interested in anything.
Is there a term for someone who lacks pleasure?
Sadistic, no? No, sadistic can be in different contexts. So if you literally look at, I think the best English word to describe it, it would be sadistic, or sadistic features, but there are people with antisocial personality disorder. Now we're talking about illnesses. In a personality disorder, one characteristic is this, not having empathy with others, like they kind of, I would say get a high, but then they would be, they would actually find it fun. It's like a source of interest for them to hurt somebody else. Yeah, so, and you'll see that not global, you'll see that that person has to have a childhood history because conduct problems, school dekhin, this indifference, insensitivity, school dekhin. So antisocial personality, and there's another borderline personality disorder. These two are the most severe ones which have a lot of, for which unfortunately a lot of treatments don't work. They are very treatment resistant, and it's a lifelong problem with, a lot of legal issues. And if we were to map the people in prison, I think a lot of people would qualify for that antisocial personality because that's one of the most, commonly known perspective if you look at people criminal behavior, like serial killer, psychopath, that inability to feel, look at the consequences, and they actually enjoy it. It becomes like a game for them, where they keep planning it. Like I said again, let's see, I may have depression, but I may be functioning. So social, occupational, work, interpersonal, and self-care. When we have problems in this area, when the functioning is impaired, that is when we get a diagnosis. Okay, otherwise we say depressive symptoms. Like if I go after a week of, or after 2-3 days of depressive symptoms, then I will not be given the criteria for, I will say depressive symptoms or anxiety symptoms. I will not have anxiety disorder or depressive disorder. Somebody who's come with hearing of voices for a week, we will put them in antipsychotics, we will consider the differential diagnosis, but we cannot say, okay, your manche is, yeah, he's not functioning fine now, but we will not say that this manche has this problem and will not never be able to be competent, function. So our the problem with our illnesses are also that they're time specific. There are people who've never recovered, there are people who have shown very good recovery. Okay. PTSD, I think for people who are working with children with trauma or survivors of sexual abuse, you may notice. But then again, just because a person has had a trauma does not necessarily mean PTSD, but it also requires a time of 6 months. So most of the diagnoses are time bound. For schizophrenia, the symptoms have to be there for 6 months. The functioning has to be comparatively more deteriorated. For depression, you have 2 weeks. So, like panic attack should happen more than 3 times to call it a panic disorder. So, like that, there are detailed diagnostic criteria.
Ma'am, I have one question. Is suicide, there are so many reasons like financial, we have seen farmers committing suicide, emotional, there may be many other reasons. Now, these are some external factors, right? Is it really a mental illness to commit suicide? There are some reasons that are triggered.
So if you look at it, what I believe, I think the ILECO suicide directive that has been formed recently, that has come with a lot of forethought because it can be a sign. Suicide can be a sign of a mental illness, but not everybody who commits suicide has a mental illness. So it's more of a, I would call it a public health problem because there's impact from every side. So which is why, when we say psychiatrists or psychologists, suicide, that is not going to happen. It is a societal problem. And like you said, finances, we can't do anything about the finances.
In the program, I am seeing that suicide is taken as some kind of exclusive mental health problem.
Yeah, it is one aspect of it. Yeah, suicidal behavior. Now you can have suicidal behavior because something went wrong. Like I think in a few of these cases, yeah, so immediate. So that is more of impulse ruled by his behavior. That doesn't necessarily have to fall back into that criteria, but we need to assess the behavior. So it's more of an acting out of a thought based on the person's capacity to to the person's capacity not being able to bear it. So we call that coping mechanism. No, कति जनाले if you say no मान्छेले भन्छ नि कति उयो गरेर त सुसाइड कमिट गर्दैन तिमीहरू किन सानो कुरामा सबैजनाको क्यापेसिटी डिफरेन्ट हुन्छ नि. Yeah. And then again, when we are not in their shoes, how do we determine unako problem, katiko impact garcha? For me, it may be different. For you, it may be different. So when we give this layman ki bekarma attention ko lagi, haurima suicide gareko, I think that's when people, when they have thoughts, they will not reach out. All the telemanas reach upon you or come to us. Thankfully, if you have a supportive family, a supportive society, or if they have met people who are going to listen to them, then at least we have saved one life. And again, there's this theory, no, that after suicide, it is not just one person. Research says that 7 people close to the person who's committed suicide have higher chances of committing suicide. So we should be on the watch, not only for the person, and the person has deceased and gone, but what the person has left behind. And that's one of the reasons why, again, the awareness, the seeking help part of it has been, emphasized. That I don't know.
That's what, it's unbelievable.
Suicide.
We can consider suicide, but I'm telling you.
No, is it suicide or is it an accident? And what is suicide? It is your interpretation, no? See, it's our interpretation, no? That horse or whatever animal may have jumped for whatever reasons. Now, how do we get into his head to say he will suicide for it? So like that, we had, I think, some of our friends remember, we had a pet monkey. Like, rescue that person sold it to my father, and the person was hitting the monkey, so rescue gareko. He was Garma, and then that when this monkey died, everybody said monkey suicide, monkey suicide. I think it is that understanding of suicide. Now the thing is that monkey, obviously monkey, but so usko chain थियो and usko जुन चाहिँ घरमा बस्थ्यो, he was trying to get out of it. So उसले चाहिँ पुरा उसले के भन्छ उफ्रेर चाहिँ that chain became tight because he was trying to jump and escape. अब दिनभरि उयो chainमा काका पुग्थ्यो तर त्यो बिचमा. So then tomorrow the news become कि ला monkey ले suicide गर्यो किन गर्यो होला. Now I think to answer your question also we need an animal psychologist to come and I think we only need to ask the question. 1, 2, एकजनालाई jump गरेको देख्यो, other person must have looked at it. Or again, simple, I mean, for the sake of amusement, they are anyways going to get killed, so it's better to take your own life than have somebody else kill it. Because you are feeding the animal because you are going to slaughter it. I am a self-aware, intellectually blessed animal, so I see I am going to get killed, so I take the easier route. Now again, like I said, I think animal behavior, we do have animal psychologists. I think they'll be able to give you a better explanation because for us, that quite does not fall into my thing. But yeah, I think it's also interpretation. Manchali suicide I don't know if you've heard, most people is suicide the whole world tries to figure out kina suicide garyo. Now bako problems they'll invent, usko bhakti. So it is their understanding that there is a problem on the garyo. Now it may not be there. So I think how we interpret things also puts a lot of light into, how that gets into our head. Okay, so for children, I don't know if we need to, but these are basically the common problems. ADHD. Not necessarily all parents are role models like that, but it's got to do with upbringing, it's got to do with okay, so that using that term itself is proof enough that the parenting is incorrect. And this was last year, no? Every day,
last 3 years I was submitting report. I mean, discussion. Most would be below 20.
Yeah, I think Sikkim statistics, the retrospective for the last 10 years has been this 15, 11 to 20 years is the second highest bracket of children who commit suicide.
Mentally strong, madam.
See, there's no answer to this mentally strong कसरी बनाउनु because what makes me mentally strong may not make somebody else. So depending on our own capacities of, let's say if I'm a very emotional child or if I have a lot of problems with my attachment because I did not have caregivers, okay, at an early age or my attachment patterns were not set, that's where I corrected. If I'm somebody who's like ajuje bhanyo bholi ल्याइदिहाल्छ आमा बाउले, so if एउटा चिज नदिँदाखेरि चाहिँ it's a problem, then limit setting. That हामीले भन्छ gratification delay. So घरमा parenting correct हुनु पर्यो. Okay, role model. Most of us हामी भन्छ नानीहरुलाई phone use नगर बेसी भन्छ. If you are 24 hours on the phone, then what are we teaching? So preaching and actually doing it are two different things. How you deal with your problems also to a very large extent determines how your children will even look at problems. Forget about dealing with it. So if somebody, let's say a person has a lot of anxiety and घरमा पुरा अत्तालिन्छ सानो problem हुँदा, what will the child learn? Obviously that problems हुँदा अत्तालिनु पर्छ, हामी handle गर्न सक्दैन. So not only on the parenting styles, it also is the temperament, personality नानीहरुको लागि temperament भन्छ. So how they think, how they believe and what works. So for a child, like you were saying, we would say one about commonly the simple answer given coping skills to help them cope up better. So there will be a set of skills, in different areas that you need to teach. But for that, the family also needs to be involved, which unfortunately does not happen in most of the cases. It will be like nani ko problem or the nani has to improve. The parents don't want to. So this is where it gets complicated. But these are the most common problems. Eating disorders, ekdamai kamti dekhcha. अहिले it's happening, but otherwise the prevalence is less. Autism and ADHD is more, and anxiety.
Ma'am, just a question. Like, not generalizing, but what we see nowadays is the new generation who's coming up, they seem to be having a lot of coping, like lack of coping skills, They tend to have more anxiety disorder, stress related. So why is that? Is it because there's too much awareness, or is it because now it's becoming a fad because you see so much content on, mental illness on social media, so now they want to be maybe the hip crowd by adopting this. But why do we see this rise recently? Because when we go to schools also, the constant complaint the teachers have is we cannot even scold them. The parents are scared of scolding the kids because they keep saying depression stress I'm going to commit suicide. So now it's reached a point where even the parents, the teachers are very scared of dealing with the children now. So in your experience, what do you think would be this paradigm shift that's happening as you know?
Okay, so like you said, the first thing is awareness. Now, if I am like, people don't think it's okay to be sad. If I am sad, that means I have a problem. I am depressed. Why? Teacher lays to volunteer, and this awareness about mental health, that sano problem boy, you over-report it, like I said, over-identification, that is happening, I think, mostly in adolescents, that group, because for once we had 5 girls coming in, all of them with panic attacks, followed one by each one, like I think first one girl had it, and in another week, week or so, we had 5 girls from the same school coming in. So sometimes it's also got to do with copying other people's behavior, sometimes intentionally, because you see the gain, sometimes unintentionally. Like you said, awareness about your own mental health, feeling that they have to be fine all the time, having to deal everything, and then if you can't deal with it, then you have a mental problem. Not all of us can deal with everything, so it's okay to have setbacks. For them, if you have a problem, if you can't do anything, then it must be because of a thing. Children come and say, "Ma'am, I have ADHD, so I can't study. I have LD, because I can't study." Of course, to understand it, you have to put effort. Most children, whatever they claim, identify as, are not that. But I think it's also about how we reinforce, as families, as parents, the kind of role models we set. If you are finicky, if at the drop of a hat you attend to your child, do not let the child learn their lessons, how will they cope up? There are people who नानीलाई स्कुलसम्म ठुलै नानीलाई now when we look at development age-wise हुनुपर्छ right? But there are people who make decisions what a 15-year-old should wear, or they have held their hands all along सानोभन्दा सानो चिजको लागि up to 10 years, and then suddenly 11 years they say that take your own decision. Now, for a person who you have not allowed to crawl, how will you expect that person to walk? And if the person has not walked, fallen down and got up again, how would that person know that falling down is okay? So that is the reason, why all this life skills education program and coping skills are being taught in school. And Amita Ajay, katti late ho, 10 years, 15 years back, if you look at Western schools curriculum, they have children as young as 3 years. Kindergarten, they train for coping, they train for emotional regulation. You have like age hisabli, you have a curriculum. But for us, I think one of the most successful programs was Euta School Mache, they could run it for 3 years. That was the maximum. Schools were not able to, even for my research, half 7 schools dropped out because they could not give time for assessment. Now, come to think of it now, at least we'd be able to screen children, because there are a lot of children who are having problems. And especially when I told you, that I see a lot of male children coming in, or adults 25 to 30 age range. Now, most guys coming in with anxiety disorder, if you trace, it would have started in childhood. But of course, they don't take them seriously or they don't know. So there are people who only take substances because they need to go to office because they cannot face that anxiety, or people who drink so that they don't have to face the anxiety. So anxiety is one problem, but to cover that, something else is also coming. And we had, I think, class 5 core child coming in with dissociation, excessive fainting, school man, everyday fainting. That was because somebody said that, the story was that somebody said in her dance co outfit she looked fat. So, oh, you are so fat, when the children laughed, and that was the point. Every day she started fainting at school. So she was in a boarding school, so she was brought and all of that. But what we realized was there was unresolved grief. So sometimes what we see, as restlessness, behavioral outbursts, are not only what we see. There's a lot underneath. For this child, she had lost her father recently. Nobody at home spoke about it, and she was very close to her father. They assumed she's a child she does not understand. She was not able to take that. So even the smallest of things brought her clinical symptoms to the surface. So I think, when you look at child's behavior, what we look at, one is a report of whatever the family teacher says, but it's also got to do how the child perceives his world in and around to be. And definitely, I think as a society, we're also becoming more lenient. School math, we obviously can't have punishments. You have children burning down the school. You have, I think, recently we had 6 boys beat up a boy so bad that he had to be hospitalized and almost be put on a ventilator or something, So it's become, I think, again, both medical and legal problem because we are the both two sides of it who have to deal with it. So I think we will wind up here because there are these disorders, if you look at it, they have a huge criteria, and like how to diagnose, when to diagnose, what symptoms are there. But I think for your practice purpose, the fact that if I were to sum it in one line, I would say people who have mental illness do not necessarily lack the competence, but at the same time, it does not mean that they would understand everything. It is time specific one. Sometimes it's also because of the illness. So, having said that, again, there are a lot of assessments which we do, and I don't think it is sensible to discuss it here. Is there any question, or can we wind up? There's still a lot more, but I think there's one going on.
Just one question. Just one question is, have you come across people who have misused the provisions of this law created for specially able people or maybe people with mental illness? Have they tried to misuse it to circumvent their judicial processes, and how do you overcome such challenges?
So I'll give you an example. Okay, I was talking to one of my friends, I was telling her. So we had this person who was supposedly classified as having intellectual impairment, intellectual disabilities. पहिला देखि स्कुल पनि गएन, that was the pretext, किन स्कुल जान सकेन. Okay, and then some PhD बाट लेखेर ल्याएको थियो कि this person he's very slow, he cannot understand, and that is the reason why he was working in the monastery. Now that person, I don't remember what he was brought by. I think it was Pokso नै होला, because that was the हतार त्यो report बनाउनु लाको कि उलाई mentally unfit prove गर्नु लाको was to escape, because otherwise there is no loophole, right? So त्यसले गर्दाखेरि, and then initially the history that his brother gave and the history that they gave seemed suggestive of this person having intellectual disability, because of which obviously he would be acquitted. But when we work now, see, intellectual assessment for me, for you, and for somebody who's not educated or somebody who's from a different background will vary. Okay? So when I assess this person, definitely yes, he had a lesser score than normal, but he was competent. He could understand what was happening. Initially, I'm sorry to say, but maybe the lawyers would have coached him what to say, what not to say, what to answer, or at the max, answer no garnu, na janeko jastai garnu. Because he showed all of that signs. But during the course of interview, he must have thought the questions I will ask were the set of questions that were given to him. Yes, he was not smart enough to figure out that questions could be asked in different ways and evaluated. Assessment ma, technically yes, usko score low aayo, but in the interview he was somebody who was able to understand, he knew the consequences, he was able to understand the crime, he knew how to go about it, and it was planned. Now a person who does not have the intellectual resources will not be able to plan accordingly. So this guy was working in a monastery. So, see, if you know law, math, or medicine, yeah, you may be smart, but that is not the only measure of smartness, right? So this guy was cooking for monks. So he would know how much to cook for 10 people versus 50 people. He would know certain kind of, certain higher monks would prefer certain kind of food. So that ability to differentiate, this is what I should do for them. This is how much of ration I should buy because I have to feed 100 people. This is how much money it will take. So all of that calculation, how he would function in his daily life, how to keep track of the timing, how the food would be prepared at what time, And see, अब तपाईँले mentally, intellectually अलिक कम्ती उयो भएको मान्छे हेर्नुभयो भने you will see patterns, right? जसमा उनीहरूले यस्तो भन्छ नि गर्छ तर गरेको भनेको जस्तो गर्छ आधा पैँचो गर्छ. This person was somebody who would cook very well. कहिले पनि केहीमा पनि कम्ती हुन्थेन and he could follow the process. So which means he has the capacity to understand, plan and execute. So that was the basis on which I made the report that yes, I feel competent, but he is somebody who can understand and he has the competence to stand trial. We had one case in which the mother was forcing me, saying that she would give me whatever it took to say that her child was intellectually impaired because that would save him from POCSO. So I told her, okay, I'll write it in your report, so maybe you can ask the judge to do that for you. So, you have people coming and saying, I'm a report banai, and they'll cry and they'll offer you things and all. So, it's so easy, basically, to answer a question, to actually misuse it. I think even POCSO, there is this issue that people are misusing it. Anything, or can we wind up? So, we'll call it a day then?
One last suggestion. Instead of treating the person who is actually suffering from any kind of mental illness, it's better to treat the person around it so that even if we treat the person with suffering from any mental illness, he or she goes back to the society. To feel this they will so one is treat the persons around some kind of counseling session, how to deal with such persons who are suffering from mental illness.
So what you're talking about are two different things here. I totally agree that yes, when you pick up somebody and says, yes, that problem, so you treat him and he goes back to the same environment, you treat that person, usko anxiety go, your depression go, your stress go, he goes back to the same environment, faces the same thing, obviously recurrence won't, right? You're right in saying that yes, the society should be treated, but again, who do we constitute as a society? We can't treat everybody. Family maybe has support neighbors who are so who all do we treat and how do we treat? Collective consciousness in terms of awareness, in terms of knowing how to handle, yes. But then when patient like treatment people who supposedly think they are okay, the only thing I think we can do in this aspect is sensitize, make them aware, make them understand. I still feel we've done a lot of that because from the kinds of programs that the legal association has held, we've seen a lot of changes. We've seen people wanting to change. Maybe previously they did want to, we didn't provide them an opportunity. Either what you're saying, treat the larger lot is so much actually sensible than just treating the person, but unfortunately we can't. So if you improve, I improve and we treat somebody better, tomorrow we'll become that society who will help this person. That's the only way we can change. Each one empower one, each one educate one. So, patience,